The world's best physios don't just treat, they coach. Welcome to the Physio Coach Podcast. This episode is sponsored by Jane App. Jane is a practice management platform that helps clinicians like you and I spend less time on admin and more time caring for people. From online booking and scheduling to notes, reminders and billing, Jane is designed to reduce the day-to-day load on busy clinicians like us. After a few years of running Better Physio Group, we wanted to level up our practice management system. 10 minutes into the demo call and I was convinced. Use code PhysioCoach2MO, that's PhysioCoach2MO, to get 2 months free. Sign up to the demo and see it for yourself. This podcast is a product of Better Physio Group, provider of physio and PT services in central London, helping people in pain, suffering with injury to feel better and live better. There's physio and then there's Better Physio.
So when I was a younger physio, relatively new grad physio, one of my friends had a really bad hip injury or hip pain. He had surgery and he wasn't able to get to a festival that we'd planned. And I remember being gutted about it because it was this big deal, big event. And he had this, we thought the surgery was there to fix him and we thought he'd make it. And he was in too much pain and he couldn't handle the festival. And I remember thinking about it, like, God, I'm a physio. Surely we can solve this stuff. And it turns out that friend was Mehmet, by the way. So Mehmet is a good friend of mine as well. We studied together. So we studied our physio course at Essex University. And shortly after we qualified, we were due to go to a festival and you couldn't make it because you had your very own hip injury, surgery, and this pain that developed after it. Could you share a bit about your story? So I think it makes sense as to how you became the hip physio.
Yep, like plot twist, we're friends. Shock. Yeah. So this is great, by the way, because normally when I say this bit of my background, I'm always thinking like, I don't know if actually people care. The fact that you've come to listen to me talk means actually I can talk about it because you do care. Hopefully you're all in the right place. That was what ignited everything for me, to be honest. And I remember it quite vividly because I had no idea what was going on. I literally had no idea. All I realized was I shouldn't probably be limping. I shouldn't be in this much pain, but maybe that's normal, for just the kind of problem that I had. And then it got to a point where it was impacting my life. It was impacting my sport, my exercise, my social decisions. No 21-year-old wants to not go to a festival because of their hip. It's a bit like, you don't really hear that, right? So I kind of thought, what is going on? Obviously I had the surgery. Like a standard young, naive bloke at the time, I didn't even know what the surgery was. I was just thinking that's something that I need to have done. And fair to say, now knowing what I know, I was the worst patient. Like I think of all the things I tell people to do and not to do, I did all of the bad stuff. Like I had the surgery, I tried to do too much, I went into the gym, I was trying to lift weights, and if you saw me do what I did, you would have thought, he's mad. Because of that, I had persistent hip issues for like 2 years. And I was like what you said, I'm a physio, like surely we've got to figure this out. And I thought, right, I need to know more about what's going on. And then when I started to learn about it, I realized at that kind of point in my life, I really don't like, if I want to learn something, I don't like not knowing enough about it. And when it was about me, I was like, right, I really want to know everything about this one particular issue. So I had FAI syndrome, I had an extensive labral tear and a really standard FAI hip. So I started learning about it. And then really what happened was I realized no one really knows much about this thing. And then years go by and then I kind of like, you get older, your hair, I had a little bit of hair left.
Yeah.
We were the two baldest people in the room up on stage with the brightest lights, by the way. And then I just thought I really find this fascinating and interesting. And then that was almost like, that's why I always say it kind of starts from this interest that weirdly just turned into my career. I guarantee not one of you are sitting here. If any of you have got a speciality in a body part, not one of you are sitting there when you're like 17, 16, 15 going, oh, I'm gonna become an FAI specialist, or a shoulder specialist. You don't. There's way more exciting things to aspire to when you're a kid. But by that point in my career, I was like, actually, we need to do better at understanding this. And that was kind of what happened. I just ended up learning and developing an interest. And I end up here talking to you guys about something that I'm like mad passionate about. Like, I don't know why I am so obsessed with it, but luckily I'm all right at managing it. Anything else, rubbish. Anything up here, rubbish, but hips I love, yeah.
It was in an era when surgery for hip pain such as yours was pretty common. It was almost like, oh, you've got hip pain and you've got these tests that seem sore and positive. You've got this scan that says this. You need surgery. How has that landscape shifted now that we're in 2026?
Yeah, I'd like to say it shifted extensively. It probably hasn't as much as I would have hoped. It varies. Unfortunately, like, we're in a situation where sometimes surgery is sexy. Some people think it's an easy answer because it is. Like, look, you know what? You've got this bony bump on your hip. You've got a bit of arthritis. You've got a labral tear. You've got this. Like, go for surgery. We'll fix it, and then you'll be fine. And you know what? What I've realised, having done this for as long as I've done it, is there's way more to someone's complexity in their hip presentation, that not just from a physical perspective, but everything else that comes around it. Surgery is mega. Like, you got to think, there is like, surgery comes with risk. Doesn't matter if you're the best patient, you've got the best surgeon in the world. You can't reverse surgery, right? Once it's done, it's done. And I think people forget that because sometimes it's just a really nice, oh, you know, you've got that bony bump there for the context of FAI. You can't get rid of that. So we have to shave it off and we have to do it. And look, don't get me wrong, I'm a huge advocate for it. It's my life, it's my livelihood is that. But there's a time and a place. There's a lot of situations where it's not suitable. And unfortunately, there's still a lot of people that are having surgery, incorrect types of surgery, and they struggle afterwards. And that's why when you go and talk to people, everyone in this room, everyone listening to the podcast who is a clinician may well have listened and heard the stories from their patients who struggle, right? They struggle with their quality of life. They're struggling with pain. They can't do anything. Their life is just governed by their hip pain. And as a result of that, they seek some sort of solace and result. Like, they want it fixed, right? And they get desperate. Now, most people in the world, as soon as they've got pain, they probably go on Google, or they'll go and chat GPT, which is a bit better, right? But they'll go on Google and they'll say, like, hip pain, and then they start reading forums. I guarantee you, there's not one person listening to this had a positive experience with something in their life and went, oh, I'm going to go and start a Reddit forum. Like, no one does that. No one thinks, oh, I've had a great, like, it's rare. Like, if you go on forums, it's all negative. It's all like, everything is like all that poor experiences. And then patients see that, and then that influences this whole thing. And you've got to unpick it as a clinician. And that's, for me, what I find really frustrating still.
I would argue that even the consultants are part of that same unintentional bias picture, because they only see the worst case scenarios as well. They don't see when someone attends physio and they get better. They don't see when someone goes to the consultant, they refer them out to the physio. If they see them again, it's because it's not working. They don't go back and say, everything's great. They just don't go back.
Yep.
So the consultants get this biased, warped version of what's going on in the world as well. And in the end, patients trust the consultant's word, and the consultant says, I think you need surgery because I've seen these hips. They always do really badly. It's like, well, no, you've seen the hips that you've seen.
Yep.
And that's why, you know, we speak about this stuff and shout about it, because us physios aren't necessarily lower down on this bloody hierarchy. It really gets on my nerves. We're in a different world. We're in the physio rehab world. They're in the surgical consultant world, right? So we've got to stamp our authority on it and be confident enough to say, you know what, in this situation, surgery isn't right yet. It might be in the future, but let's just see. So let's imagine you, 21, 22-year-old you, walks into the physio clinic and you're the physio. What are you saying, and what are you doing with that person in that first session? How do you help that person understand what's going on with their hip? Because what you were saying, they've got impingement and there's some labral damage, there's some degenerative change already. How do you help that person understand their journey?
That's a good question, Chaz. The interesting thing is I see myself in like so much of what I see now day to day. So I kind of, and to be honest, I've never really reflected on it to that perspective, to think, oh, you know, you're going through what I went through. Because I try and I try not. Sometimes to be honest, I'd say 99% of the time, a patient will never know that I had a hip issue. Like, they're not coming to see me, like for my story or anything like that. Sometimes they like that and they have that insight. So they come with that and they want to learn, and they appreciate that level of like personal empathy. But like, putting that all to one side, my initial appointments with the patient is so much less about, and I'm talking about this in the context of whether we've got a diagnosis or not, so much of it is less about physically examining them, but like getting to know their history and their narrative, right? There's so much information you get about someone with things like that. Like, you got to consider, if someone's coming to you and they say to you, I've had pain, this could be anywhere, right? They've had pain for 1, 2, 3 years. You've got to essentially get all that information, 3 years worth of information, by the way, in your hour's appointment, half of which you're going to do your assessment, some of which you've got to do your notes, some of which you've got to do an exercise plan, otherwise you're going to be delayed. And so you've got like the best part of 30 minutes to figure out the patient, their personality, what they're anxious about, what they're stressed about, what makes their pain worse, what they've done, who they've seen, where they've gone to, what their beliefs are. Do they know anything about what's going on? So that's a lot. So what technically could I get from that to influence in certain, and the best feedback that I get, the best feedback that I enjoy hearing, is when a patient will email me after their appointment, or maybe at the end of the appointment, they'll say, like, I feel really reassured. That's like the best feedback I can get. Like, I feel really reassured. I really understand now, like, what the situation is. You listen to them, and off the back of giving them a little bit of whatever it is, education, I don't think they don't care how clever we are. No patient, they don't want to be bored by it, but they need to know that you've listened. We've got a plan. They appreciate your like authority of what's going on as a physio. And then you can start structuring all those other things. So it is, so much of it is that, and people think as a hip specialist, it's the opposite. They think, it's going to be like these clinical tests and this special, and like that comes in time. But like, people are so complicated.
People don't care how much you know until they know how much you care.
That's very good. Did you make that up just now?
I wish.
Right.
It's a famous quote, and it rings true in my head every day in clinic. It's like, that's the first option. That's the first priority in a session. Exactly what you just said. And then there's the other bit. I can't remember it's a famous physio who said, reassurance is a bloody good painkiller.
Yeah, I made that up.
That's your one, is it?
No, I don't.
But it's those two things just show you there that we'll get onto some of the other technical parts, but that's the priority number one, getting those two things right. So then your patient in front of you is feeling reassured. They understand that you now give a shit. What's next?
What? At that point, then we need to kind of figure out how we're going to implement our plan, right? So I'm all about strategy. Like, I need to know, I try to my best to have, and I do this when I teach as well. I say, like, imagine just someone is in the back of your ear saying, why? Why are you doing that? Why are you saying that? Why are you giving that? Like, I need to be able to answer that myself. So to do that, I need strategy. I need to know what I'm going to assess. I need to know why I'm going to assess it. I need to know then what I'm going to do to try and manage it. Now, you can't figure out what you're going to assess unless you've done the bit before, because that's going to essentially, in your mind, give you your kind of strategy A, which is, right, I need to go and kind of, to the best of my ability, prove that it isn't that. So the way that I approach any appointment, and sometimes I say this to patients, like in my appointment, I'll say to them, especially when we're going through the education bit, I say, look, it's easier for me to tell you why this is why I've surmised this outcome. I'm going to tell you exactly how I think. It's because actually it's easier for me to explain it to them.
Yeah, commentate in your session.
Exactly. Because I'm like, then I don't need to overthink it. Let me just tell you what's in my head. I said it earlier in my last appointment before I came. I said, look, when you walk through the door, I thought it could be anything because I'd never met you before. I don't know what's going on. So I thought, it could be anything. And I said, but then you walked in, saw your age, saw your gender. You started telling me you've had it for 6 years. I was like, well, I presume you've not like got a septic joint because you've had it for 6 years. And I just kind of make a joke. I say, look, there's things that are really obviously it isn't as soon as I'm talking to you. So I'm putting all this thing to the side. And my job by the end of us having a chat is to think, if I said to you, I think it's whatever, FAI, I need to go in. I think like if I go into front of a judge and have to prove that it definitely isn't this, would I win my case or not? And the only way I can win that is by building a case. That's everything we're doing is building a case by the questions that I ask and by the things that we're going to assess. And sometimes it's really tough. And sometimes you'll have about 4 different things at the end of it. And that's all right. Like, it's all right to not be definitive. Like, embrace the ambiguity and have the confidence in yourself to say, look, it could be this, it could be this, it could be that. Like, it'd be really remiss of me to say it's definitely this, because you can get that level of, what's the word? You can get that level of certainty of people who probably don't know as much, and all you would need to do is go on Instagram and you will see that level of certainty in abundance.
I've got really comfortable in the grey in the last few
love
years.
the grey.
Yeah, confidently sitting on the fence.
Yeah.
It's the ability to say, it could be this, it could be that. Here's how we're going to find out one way or another. And then the plan emerges from there.
Yeah. And the thing is, I think patients like that.
Yeah.
Don't get me wrong. There's a way that, like, you need a degree of confidence to be able to articulate that. You can't be like, oh, I don't really know, it could be this. And
confidence and competence.
Yeah.
Right. The competence kind of comes first, right? And at that point, once you realize you've got the competence, you start to build confidence in your communication skills.
Absolutely. But that's where that narrative comes in, though. Because if you're saying, oh, it could be this, it could be this, it could be this, this is why it could be this, or it could be this, or it could be that. I can't prove it's not one or the other in front of the judge. Sometimes I need to reinforce the fact that, like, we're not going to court. I sometimes say that analogy, people are going to like sue me. I'm like, this is an actual court. I'm just giving you an example. And it helps. And I think that's why I think that physios really need to put, I'm so big on just educating, on just get good at talking. Like, it's just, you can't beat that. If you're good at communicating, the rest of it is so easy. Like, it doesn't matter how many tests you know, how many exercises you know. People think sometimes I gatekeep some like secret hip physio exercises. They're all the same. Like, I don't know some secret stuff. It's all the same shit that we all do. It's just the way that you strategize your management of it.
I've said for a long time, I think I'm an average physio, but I'm an above average communicator. And as a result, I think I get better results than the average. So that's actually one of the things I've spoken about on the podcast before is that hosting a podcast has made me a better communicator. And for you, actually, your journey is intertwined with something similar in that you started to put content out there. That was 2020, 2021, something like that, right?
Yeah.
And we actually first started to, we were all bored in lockdown, right? Everyone's bored in COVID lockdown. And myself, Mehmet and Andrew, our other friend, we decided we'd do some stuff about educating. And we put some stuff out there called the health space. We were practicing just putting content out. And we were going to do it all as a 3. And I think Andrew said to you, it's like, you know what, you should get Instagram. You should get an Instagram account just to practice. And you were like, oh, all right. And about a month later, he had about 10,000 followers. It was ridiculous.
And I was like, see ya.
Like, turns out he's really good at this. He was like, no, yeah, you go and do your own thing, mate. So he went off and became the hip specialist and the hip physio as he is now. And went from strength to strength. And it was all part of you kind of figuring out how do you get better at communicating, right? And now you're, a leading voice and, should I say, an influencer, a global influencer. So it's quite, how did that I've given the audience a bit of an insight into my version of how that happened, but how did that map out in your mind? I assume it wasn't necessarily deliberate from the beginning.
It definitely was not deliberate. The fact that someone had to ask me, like, can you, because I remember it so vividly, because Andy was like, get Instagram and then we can share the links for the podcast on Instagram. I was like, all right then. I better make my own one up, because my one currently has like my lawn, my wife, my kids, and then like my dog. It's not the most professional. So I just created a new one. I thought I need to post something. I really can't be bothered to think about stuff that I don't know. And I'd already started putting my course together at that time when I was in my other employment. And I thought, actually, I could just use the stuff that I already know. So I started putting stuff out. And then I realized there isn't much of this stuff online. And it went full circle to when we said the thing at the beginning, almost like rewind like 16 years before. I really don't like not being good at something. So then I was like, how do I do posts? How do I do graphic design? How do I do Instagram? How do I do any of this stuff? So, and luckily, obviously, it was lockdown, so I had nothing else to do. So I was just researching so much about social media, psychology, marketing, designing, all of that kind of stuff. And luckily I had the content. So it all kind of snowballs. And then I was like, okay, this is pretty helpful because I'm kind of being able to do kind of two things. One, talk about the stuff that I really like to talk about. Two, people actually give a shit and they're listening. And three, like this is a bit fun because it's different. It's not the same as just like the same old physio type stuff. And that's kind of what's really made me passionate about, we'll probably talk about it later, but trying to change like you are with this, trying to change the landscape of like what normal physio is, because it's way more from a business perspective than just appointments. And the more that people can get involved with that, the better the landscape will be for physio. And more people realize that we don't just massage.
I think it's so true. And I still put my hands on patients, right?
What?
I still put my hands on.
I know you're really bad. You're not allowed to do that.
And something that I'll come on to is how you manage that dynamic online, because I've always struggled with online physio. I've not found a way to get the same level of enjoyment from my job doing online. And I know you've created a business, partly through online appointments. And there's something about certain people that their pain almost needs to be palpated, right? We were saying people don't care how much you know until they know how much you care. People don't care how much you know or how much you care until you found their bloody pain.
Yeah.
Right. So sometimes that can be really powerful.
Yeah.
And yet you've made a real success out of online physio, and a lot of the listeners will be doing their own online stuff. Many people out there only do online physio. So how do you make it work?
Okay. So this is a great question. The remote physio stuff that I do, I really enjoy. And I've had to evolve it in some way more recently for the reason that I'll kind of touch on now. One of the things, and this is not me, and I really mean this genuinely, and anyone that knows me knows like I'm really just transparent with stuff, and I weirdly hate talking about my strengths, but just for the point of this, for people that are listening, it's worth knowing. One of the things that I really value as one of the things that I try to passionately be good at is building rapport with a patient ASAP in any context. And I've really tried to develop my skills to do it remotely on a Zoom or whatever it is. And you can do it. And you'd be surprising how effective that can be to pacify that barrier of, oh, actually, like, this is remote, this is online. And you can do it, and it's a skill to do it. But if you can do it, rapport is like an immense skill set to be able to build with a patient, because you could not even know that much. If you're really good at rapport, you could rapport them better.
We all know physios, right? We all know physios that aren't that good, but just connect like anything.
Yeah.
Right? Everyone
knows. I was
physio.
never academic, believe it or not. I really was average.
I believe it.
Yeah, thanks, mate. Reckon. I was average, up until the point, I've done an undergrad and 2 masters. And the only time I was ever half decent was when I was literally doing my physio. The rest of I was at school, I was rubbish. I wasn't rubbish, but I was really average. GCSEs, average. Parents hated me. A-levels, scrape by. Did sports science first because I couldn't get into physio. Then I went into physio. I was like, right, okay, I'm actually all right at this stuff and I enjoy it more. So you're not always going to be the most academic. It's just being having those skills. So what's enabled me to also overcome that barrier is making the patient understand what it is that their treatment is going to involve. I'm lucky in the sense that the patients that come to see me, 1, have often seen physios, 2, have come from their physios, 3 are physios. And we already I don't need to sell myself of what I'm going to do, because they come knowing I need your expert consulting opinion. And in certain scenarios, and I've done it today with someone who is a professional athlete, I say, look, I will take care of your rehab from start day 0, surgery is next week. I will be your lead physio. I want you, because it's in Belfast, I was like, I need you to have a physio local to you that has no ego, that is happy to work as a team collaboratively. Because there are people that are way better at stuff than I am. There are people who are for psychological support that do it for their job. There are people that are like hands-on, way skilled, better than I am. So it's about presenting that. Like you said there, like your team, like that is like fine to do with certain patients. And remotely you can do that because you're essentially just like being that strategic planner for what their case management is.
Feels almost like your role has become like a sports medicine consultant. You know, the sports medicine consultant.
Yeah. Okay.
Because the way that they signpost and move people around and understand, because I know you're pretty hot on scans as well these days, right? You can look at scans, and these are all skills that I certainly don't have as a physio, but it seems like that's how you've made that online work, is that you know you've got a big enough network and a confident enough skill set to say, actually, you need this person over there, that product over there, that service there. Yeah. And then they get the best outcomes.
We did it last week.
Yeah.
I had a patient that came in to see me. I was like, you've got chronic pain. I'm not good at this. Charlie is. Go to Charlie. And that's fine. Like, I'm like, and not in that way. I just said to her, like, you know, that's fine. You don't need me. You need someone who's better at managing this in a slightly different way, more consistently. Because sometimes I might not be able to see someone for a month. In that situation, that's not helpful.
Yeah. And actually, they came through our system, and then we recognised it was a chronic pelvic pain case.
Yep.
And Tim Beams is in our team. That's literally his specialty. So they'll see Tim, right? So it's the confidence to say, it's not quite my bag. It's not quite my thing. And that's what I was getting at there. It's like the sports medicine consultants do some treatments, but the most of the things they do is referring out and getting people to have those diagnostics and getting them in the right place.
I've just realised. So she booked.
Yeah.
I definitely haven't had my £50 voucher.
It's on its way.
And just remember that. Don't let me forget.
Nice. Let's come back to you, actually. Let's come back to your case here. So young Mehmet's walked into old Mehmet's clinic, and you've connected. You're getting on like a house on fire, as you'd expect. He's got this scan that says FAI, labral tear. He's been told by the consultant he needs surgery. He's in a lot of pain. He can't play the sports he wants to play. What conversation are you having there, and what kind of things are you helping him understand about making that decision?
Okay, so in this scenario, I've got certain things that we need to kind of iron out before we kind of get down to the nitty gritty of surgery. And what I have is almost like my checklist of things that in my head I'm trying to look out for. I'm thinking, first and foremost, like, what have you done to try and manage this? Point one. Like, what kind of physio? Because people sometimes say, I've tried physio. I'm like, what have you done? What physio is it that you've done?
Well, let's answer that.
Okay.
At that point, with your case, how much physio had you done?
None.
Right. And that's a common situation, right?
Happens. But in that scenario, sometimes they have either done none, good, thick like me, or they would have done something. The problem with this stuff, guys, is sometimes that something is the worst thing that you could do because it makes it worse. Might not physically damage it, but it makes their symptoms and problem worse. So in their mind, they're thinking, the physio's not worked.
So you're specifically saying, have you had physio, and what did you do with that
What's
physio?
it look like?
Yeah.
And the way I say to them, like, has it had why have you done it? Have they told you why you're doing it? Have you had a strategy? Have you had a plan? They turn around and say, well, I've done a bit, I've done and they in their head, they say, oh yeah, I've done like this one and this exercise and that one. I'm like, yeah, but you've had it for 2 years. If you're telling me 3 exercises, like, what I want to hear is, well, I've done it like block by block. We progressed it. We kind of focused on this and this, and it's still not improved. My first question at that point is, why? Why hasn't it improved? Have you even got the diagnosis right? You know, is it actually that's causing your symptoms? Because most young adult hips who are quite complicated rarely just have one thing present. If someone has a cam and a labral tear and there's nothing else, you're flying.
They probably don't come to you because they've probably already been solved elsewhere, perhaps.
Possibly. But there's so much nuance to like hip anatomy, pelvic anatomy, and coexisting conditions that will negatively influence surgery. So we've got 1, have you done the right physio? 2, do you know that the diagnosis is correct? 3, do we know why your hip hurts? And at that point, if we can prove all of these things and you say, right, you've done that, then I need to figure out the patient. Is the patient a suitable candidate for surgery? as a person? Is a patient psychologically resilient enough for the surgery that they're going to have too? So it's almost like you're thinking about two contexts, the medical side of things and then the patient side of things.
Let's start with the medical. How do you help them understand, or how do you understand what is causing their pain?
Oh, okay, this is fun. I like this. Okay, cool. So look, you've just said to me, why does their hip hurt? The big question to ask. I don't know if I'm going to be able to answer it, but I'm going to go through my strategy of what I would think. Right, so let's say, for example, this person in front of me has nothing. As in like they've not seen anyone, they've not done anything. They've come into
blank slate.
The blank slate, right? They've come in to see me, and I'm looking at them, I'm assessing them, I'm thinking, right, I reckon you have hip dysplasia, or I reckon you have FAI syndrome, or I think you might have a bit of both. Then I think, well, if your hip hurts, structurally, the thing that's going to cause you pain is not going to be your weak ligament. It's not going to be your shallow socket. It's not going to be the cam bony bump. Like those things are not the thing that cause the pain. They are causing something that is painful. So I'm trying to deduce where your symptoms coming from at that point, from a physical perspective. Now, at that point, what I have then done is I've built up my case. I've then gone to the judge and said to the judge, I cannot prove to you this isn't FAI dysplasia and a labral tear. So how do I prove it? Well, then I need some sort of imaging to start building my case up. Because if my imaging is done and I have an X-ray, there's no cam, there's no pincer. I'm like, well, my case for FAI is, for it not being FAI, is building. But I can't prove that it's not dysplasia. So I've had a 3D CT scan, full, lovely, like one of these sexy PDFs. Like there's no undercoverage, there's no evidence of hypermobility from the assessment. The joint looks good. So you're kind of building up your case. Those risk factors aren't there. Sometimes they are. Then you have the FAI.
And I saw you deadlift, by the way, and I'm convinced it could never have been dysplasia for you.
Yeah.
So
I don't know what you mean.
You're a very stiff man. So it's unlikely that would sort of move my thinking as.
And I think that's also why I'm back, but that's another situation. So in that scenario, if you think someone's got, let's say, FAI, and we've seen the cam bump, nice textbook, easy. I still said to you that's not the thing that hurts. So the thing that hurts is the labrum, and they've had their MRI, and the MRI's come back, labrum is torn. You think that's why it hurts. Well, like if I said that to the judge, he'd arrest me and put me away because I'd lose my case, because we know that loads of those things are asymptomatic. So how can I prove that that's the thing that hurts? Well, they've had the injection in their pain weight for 4 months, or at least improved it for a period of time.
So at this point, you've brought someone else into the team, right?
Yeah, because I can't do that. Yeah. So you then get the imaging, building up a case. You've got the injections of the diagnostic. It helps facilitate that picture, the clarity, right? And at that point, then you're starting to try and understand, well, like, if I know that's the thing that hurts, the next task is trying to figure out which of those things has caused that to become a problem, because that might be the thing that if you need surgery, you have to get right the first time.
A little side case, one of my long-standing knee rehab patients has developed hip pain in the last couple of months. And he has ended up getting bilateral MRI. He has a unilateral hip pain, and he obviously, as you would expect in this story, has bilateral cam and bilateral labral lesions, right? So he's got these two, they look the same both sides, but he has unilateral hip pain. And he's now, I haven't seen him in clinic yet, but I know he's going to come in and say, oh, good, the MRI has shown me where my pain is.
But yeah.
And it's like, well, you've got it on the other side, so we don't know that for sure. And we don't even know if this side's painful, let alone that side. So yeah, so that's where that complexity builds, right? And you've got to have the confidence with your communication to convince that person you know what you're doing. And it might be that he has to go and have one of these injections, diagnostic / therapeutic injections, to see whether it works or not.
Yeah, it's sort of treatment. That's the thing. You got to tell them, like, we're not doing this to treat you. We're doing it to kind of get like insight, and then that will guide the treatment. So then we've got that kind of thought. We've got what's going on, what's painful, and I'm getting a bit of insight as to like why it could have happened. But then you revert back to like, well, you've not done the physio. We need to do the physio, and we might come on to this later. At that point, like I try to give that individual like. You remember I said to you strategy? I was like, the strategy for a patient is they need to know a plan A, they need to know a plan B, they need to know a plan C. The plan A is physio, because that's our bread and butter. Like we'd be out of jobs if we didn't. try physio first. So most of the time you would try that. You're not going to do physio forever. Like these things, you're not going to like be 3 years down the line and go, all right, it's not working now. We might as well go and look into it. Also, they need to know a timeline. It's not going to be 3 weeks either. So you need to be pragmatic and think, well, we need to give it a few months. And I always refer to them, these scenarios, when I talk to patients and I say, imagine I gave you 10 grand today. And I said, come back in 4 months and I want you to give me profit. That's what, like that we'd be buzzing. If you came back and you gave me 100 grand, I'd be fucking blinded. Huge return. If you gave me that 100 grand and said 2 months ago, I was actually almost at a loss, I'd be like, I don't care, because I'm counting my money. Like your rehab needs to see a net gain in what you're doing, but you have to kind of figure out like the whole picture is going to be up and down. But what you don't want to do is get to month 3 and be in a net loss where all you've done is be in flare-ups and go up to baseline, flare-ups and up to baseline, and get to month 3 and go, right, I tell you what, we're going to do this for another 6 months and hopefully by 9 months you'll be better. Because you think, why have, like, if you're doing the right things, by month 3, you want to see something.
I'm really strict on this.
Yeah.
Really strict. I have to see genuine progress with something meaningful. Otherwise, I'll be very honest with them and say, things aren't working out here.
Yep.
We need to figure out why. And then that's where plan B comes in, right?
Yep. And then plan B is discharge them, send them to or something. No, but like, and that's, the thing is, like, joking aside, I think, again, like, if you're confident in the thing that you're doing being the right thing that they should have, why aren't they getting better? And I say it to patients, I'm like, look, I don't, and I say, similar to what I said to you about the other stuff, I said to them, look, if this is what we're going to do, it should help. Like, also, I can give that with a bit more certainty because I only see this stuff. Like I said to you, I'm honestly so shit at all this stuff. I've forgotten all the bones that are in the ankle. I can't even remember how many nerves we've got in the arm or whatever. But like this stuff, I see day in, day out. So like, if you're going to get better, it should help. And if it's not, why isn't it getting better? Then what do we do? But in other scenarios, if I think actually it's out of my remit, I need to kind of outsource that. I need a little bit more knowledge. And that's when my network is really small. Like I've got trust issues with medical professionals. Like I've got like a couple of surgeons, couple of sports consultants, the end.
Yeah. But if you get some good ones, that's probably all you need, given that
it's really hard because they're like really busy.
Yeah.
But yeah.
Yeah. And with that plan B stuff, I'm pretty confident that as a physio that loves prescribing rehab, that if someone is doing their job and I've done my job, they'll see some progress. And the way that I will then track that is using some level of testing, some level of objective testing. How do you intertwine that in your journey?
Yeah, I do, but I don't do the same for everyone. I don't think you need to for everyone. I've got, you know, lovely, sexy, bald equipment. Some people love that stuff. They want to see the data. They want that to drive their decisions. Sometimes people come in and they are in a lot of pain because they've got a mildly arthritic hip and functionally they're impaired. They might have a really stubborn, problematic gluteal tendinopathy they've had for 18 months and they can't walk. They don't need me testing their abductors with their board. They can't stand on one leg. It's irrelevant. So I try to kind of judge my decisions for that. So their objective measures will be their functional incapacity and then reevaluating that. On the flip side, someone who is at a higher level or wants to achieve more, their rehab is going to be more robust. So I then need to try to justify why I'm doing what I'm doing. So this has twofold, right? On one hand, I'm saying the data and the testing is going to govern some of the choices I make. But I can't then prove to you that your hip hurts because that you're weak, like, because that's wrong. Because I guarantee anyone listening to this, they're going to have some, like, if we tested your abductor to abductor ratio, I'm sure there'll be some asymmetries. I'm sure you're all fine. So it doesn't then precipitate injury for everybody. It's about just understanding hip, almost like where and when you would use it.
Comes down to communication again, because often that's what I'll say. It's like, look, worst case scenario, you're stronger. And you still have pain. We don't necessarily know it's going to fix your problem, but it might do. Here's why. Here's my analysis of the data and the assessment. let's trial this, and if we see progress and we see improvements in your pain, then we're happy, and your functional improvement comes along with it.
True.
And we're happy. But if it doesn't, I guess that's where you're talking about plans.
Yeah, absolutely. And look, the thing is, no one's ever walked into, I've not met those people here, but like I can guarantee no one would have ever walked into their clinic room and said, oh, I'm just too strong. Help. Just doesn't happen. Like,
I know what your problem is, mate.
yeah, you're just too big. Your quads are too big. But like, we see a lot of weakness, a lot of intolerance. And
I think there's a correlation. I know it's really hard with studies to let it be, to consider it as causative, but there's a lot of correlation that seems to happen in my experience, and it quite likely isn't causative. It's sometimes side effect of other things, but that's what I mean by worst case scenario. You're stronger and more stable, and therefore more likely to deal with function in the future.
Yeah.
So
this is why, and sorry to just like sidetrack, but like, I mean, it's a podcast for us. Like, we're literally only here to do this. So, but like one of the things I really like with that sometimes people take to the extreme, which I'm not like, I hate slating other professionals because I'm really against that. But there is also non-physio practitioners who are like super hyper analytical with like biomechanics, and it does my head in, where they're like, your pain in your hip is because your knee is like a little bit inwards, and then your toe is that way, and then because of that your pelvis is like this. Like, I think patients have got enough to think about. I can't even make that make sense sometimes from the stuff that I hear, and patients tell me what they've been told, and I think, am I missing something? Like, and then I think, actually, no, I know a lot about this stuff. And the fact that I have no idea what you're talking about means it's probably irrelevant. I don't tell them that. I just say, oh, well, like, you are here today. So, it's obviously not worked. Maybe we could try not doing your rib alignment.
And on the flip side of that, I agree, sometimes people take it to the extreme. Sometimes people just move really poorly.
Yeah.
And it's relatively straightforward to change the way someone moves, if it makes a difference. And I think that's what we have to keep, like, you keep saying why. Can we take it to the judge? That's how I think, right? But I haven't necessarily put it in that metaphor, but I'm always thinking, is this thing I'm going to try and encourage some level of change worth it? Is it worth their effort, and is it going to then lead to some level of outcome on the other side? I don't always know the answer to that, but I'm trying to make that case to myself, and therefore then.
But that helps. I think like it's just when it goes to when the patient is worried. Like, let's say, for example, in that scenario, your patient gets stronger and they have less pain, but when they're walking, they've still got a bit of a knee valgus, and they're like, oh, but it's not still not like straight. And you're like, oh yeah, but you are all right now. So it's obviously like, so there's a balance, right? It's a balance, but it's just when it's too hyper analytical that I think it's maybe one step too far. I think with those things.
Young Mehmet is doing his homework. He's gone away.
Oh, like, you stop saying it. You make me feel so old. You're saying young Mehmet, like as if it was like 100 years ago. I'm 39, by the way. I'm not like nearly retired, but thanks. Anyway, sorry.
21-year-old Mehmet.
Thanks, mate.
Has done his homework. He's done his exercises. He's stronger. He's moving slightly better, but he's still in pain. He's still struggling. He can't quite get back to doing what he wants to do. He's gone back to football. He's gone back to the gym, and he's flaring up in pain. What's next steps for?
This is before anything else. This scenario. This is
non-surgical at this point. You're trying to help him understand his options. This is in the physio clinic.
This is okay. So I think it's really pertinent to make sure that people in that scenario, when you're in your 20s, by the way, it's not normal to have hip pain. But when you've had hip pain for years, even a year, it's normal. It's not normal. It's not normal to have hip pain. Like, no, you're not meant to be 23 and think I can't go to a festival because of my hip pain, or I can't walk. Like, so they need to know that. But sometimes because people have hip pain, and I see it, I'd say, look, if the context that I see it the most of is young female patients with hip dysplasia, is like the caseload that I see where it's like the greatest burden on their quality of life. You're in like your early 20s and you've already had pain for like years and years and years. And what happens is your expectation is down here, in that the goals and the hope is I just want to sit with no pain. Imagine that, being in your 20s and your goal is I want to sit with no pain. So I actually tell them that's not good enough. Like, I'm not unvalidating your expectations and goals, but your goal shouldn't be I want to sit more. Your goal should be I have no hip pain. That needs to be one of our plan B or our plan C, or at least the plan A and B is seeing if it works. And if not, worst case scenario, plan C, you would only ever have surgery for you to have no pain. And unless there's a scenario where you are unable to do certain things, like you're having a hip replacement and then you want to go and play professional football, there is a limit to this stuff, right? If it's not that extreme, most things are fair game. So you saying, I just want to sit for a bit longer, or I want to walk a little bit longer, so you bloody should do that. Like, that's why with the physio stuff and that profit loss type thing that I was saying, even if we are at 3 months and you're getting better, even if you're at 6 months, 9 months and you're getting better, but you're still not normal, that's still not normal. Like, there needs to be, like, our objective is you have no pain. Because if you're 21, I don't want to talk to you when you're 31 and you're still in pain, because you'll be depressed. And so then how do we get out of that? Because something's got to fix it. Like, something has to fix it. Like, it's just, there's no two ways about it. Unless you've got like some sort of like terminal condition, with these kind of scenarios, there is a route out. You just got to figure out like what the route out is. And sometimes it's quicker if you find the route first. But the reason why like the average time for people to have symptoms with hip dysplasia before a diagnosis is half a decade, that's shit. That's an average, by the way. My maths is really bad, but I know that that means some are higher than 5. And the average age demographic is 20 to 30. You think that's no good. So how do we make that better? Well, we don't just overdiagnose everyone and then hope the averages go down. You just think, well, what's going on? If you can try and figure out why, all these other things, doesn't have to be that complicated. If that makes sense. I don't even know what you asked me. You just start talking about, this is what happens. You ask me a question, I get really excited, and then I just forget.
You half answered it.
Well, what was the question?
You half answered it. You basically, my interpretation of that is don't tolerate long-term pain.
Yes.
Right. My question is, what do you do with 21-year-old Mehmet who's struggling along with he's getting a bit stronger, he's doing his exercises, but he's still in pain.
I remember now. I mean, you're really polite. I didn't half answer it. I didn't answer it at all. I'll answer it now. So we've done the physio and it's not worked. So then we would do, let's say we've done the imaging, we've done the injection, and we know kind of diagnostic.
Injection worked. 3-4 months. Injection
worked. So we know what hurts. And we know maybe like the causes why it's happened. Then if our plan C is surgery, we've got a big question on our hands, which is who is going to do it? And you got to pick wisely, because is anyone oh God, okay. It's a bit awkward. I can't ask it now because we're live, but hopefully there's no surgeons listening. I'll just not say it. So choose your surgeon wisely, because a hip arthroscopy or a PAO is a very hard skill to have. And it's a very different skill to a knee arthroscopy or a shoulder arthroscopy. It's a big procedure. I'll give you a main kind of point as to what will reinforce this thing that I'm trying to say. The biggest cause of revisions for hip arthroscopy is leftover from the first surgery. So legacy cam or incomplete labral repair. That's surgical.
So that's an error.
No, Charlie, it's not an error. It's just...
It's an error.
Well, I'm not a surgeon. Imagine me sitting here talking about surgeons, say, call him an error, like as a humble physio, but it's skill set. Like, and if there is a bit of cam that's left or a labrum that's not repaired, or if the patient didn't even have a labral tear because of the cam, things get worse. So you have to have a surgeon that pretty much only does that. And that's not the case, because around the world, you will have patients that have surgery from a surgeon who in a week might have done 1 arthroscopy, or in a month might have done 4, versus someone who every week might do 6. And you don't want a surgeon, realistically, who's going to be doing your arthroscopy or your PAO, that's going to do an arthroscopy in the morning, fixing someone's bunion before lunch, and then maybe trying to do someone's ACL before their dinner. Like in reality, like these are really specific things for each of this stuff. For any of those things, I'd always say you're better off seeing someone who does a lot of it. So the answer to that is, if the physio has not worked for young Mehmet, and we know the diagnosis is correct, and we know that they're going to need surgery, we need to find the right surgeon, if you can, because obviously sometimes, especially with NHS, you don't have that luxury. So you're kind of governed by who they end up with. Hopefully, they end up in a young adult hip unit that sees it a lot anyway. And we've got some of the best NHS young adult hip units in this country that you'll probably find around Europe. And it's sometimes just luck of the draw. The challenge is, there's only a few of them. So like sometimes you could be in, we don't have it in like the Outer Hebrides from what I know. So people have to travel and so it's just those kind of things that you'd want to, have I answered it now?
I think you've answered.
Thanks, mate. Thanks.
And we know because ACL is the most studied problem in MSK physio. So we know that prehab works really well for ACL surgery. Is prehab just as effective for hip surgery?
Oh my God, yes. Like so I see prehab as way more than just exercises. In my head, I kind of for my patients that I see for prehab, I kind of have it for every level. For the arthritic hips that are waiting for a hip replacement, for the FAI ones, for the dysplasias. Prehab for me is preparing you for surgery. It comes down to educating them from a diet perspective, what they need to prepare themselves for before, after. People aren't going to want a nutritionally optimizer like intake when they've just had surgery. Half the time they're not eating or doing enough, and then certainly not probably hydrating enough. So it's just giving them things to understand beforehand. So they've got time, they can research, they can read, they can prepare. Getting someone physically able is one thing for sure, right? So giving them exercises that are within the remit of what they can tolerate is really important, but also not going mental and saying like, just because you're having surgery, go hell for leather, because I don't think that's beneficial. I don't think it's, let's just make it really bad because you're going to have surgery. My perspective of this, it's not right or wrong. This isn't evidence-based. It's just common sense. Like, go in feeling a bit better.
There's a reason why the ACL surgeons, the knee surgeons, wait until the inflammation is settled before they operate, because they know the outcomes are better.
Well, and it makes sense.
Yeah.
And like, because you're going in at a stronger, more enhanced kind of position with that stuff. And then I think, well, if I'm with someone, let's say I speak to someone 2 or 3 times in the run up to their surgery. So it's this kind of prehab type thing. Educating them on what the surgery is, educating them on what the recovery is going to be like, setting their expectations for recovery, what their normal pain and abnormal pain responses will be. Like, doing all of this stuff psychologically just builds a degree of resilience for them to know, like, what am I going to expect? And I'm really candid with, especially with people having replacements, right? I'm just candid with them. I'm saying, and I do this not to be nocivic, just to be like, I'm like, look, you're going to have your hip replaced. It's going to hurt. Like, no one can have their hip replaced and it not be painful. Don't go into it thinking, they've replaced the ball and socket and I'm going to wake up tomorrow and it's going to be great. You're going to be in pain. The anesthetic might screw you over. You might faint. Like, just, if this stuff happens, don't stress out. If it doesn't happen, don't think it hasn't worked. Like, it's just normal. These are things that occur typically. The understanding is, if it does happen, what do you then do to manage it? And that sometimes helps someone overcome that afterwards, versus them thinking, the arthritis has gone, why does it hurt so much on day 3? And sometimes it's the same with other surgeries as well, where it's a PAO, etc. So coming back to your point about prehab, it's the kind of non-physical preparation, it's the physical preparation, and it's the kind of other kind of social, nutritional type things as well, that, time off work, the amount of time they're going to need. So you're almost like coaching them to get them ready for it. So they're going into it thinking, right, I'm prepared. And I think that's sometimes why I kind of see it as like, well, it is prehab, but it's more than just exercises, right? Because you're not going to really do much with a joint that doesn't move, for example. You've already tried it anyway. Your prehab has been the months that you've done physio.
We're going to take a quick ad break. We'll be back soon.
Something we really love about Jane app is the way things look online. So when you click book an appointment on our website, it directs you through to Jane app's booking system. And the colours are nice, the design is good, we're able to make it bespoke with our logo, with our colours. You can see the faces of all our providers straight away, so people can click in with who they want to book with. If you've got different locations, you can click in which location you want to book. It just makes things look really professional, really slick, easy on the eye, and really in line with our branding. Another nice thing about the online booking, you're able to put a little note on the top, so you can put messages there about different things that are important. But what we've used it for is it shows the insurance providers that we work with, and it shows the insurance providers that we don't work with. So there's no complications, no friction when someone books in by mistake and then they get to the point of the session and then we have to tell them that we actually don't work with the insurance provider that they're with. So it's actually taken away quite a few complications that we used to have with previous systems. And now back to the episode.
We're going to stretch the story. We're going to keep stretching the story. It seems to be working. So young Mehmet has had his surgery now. Okay. Firstly, what was the surgery exactly?
Arthroscopy for cam, pincer, and labral resection.
Okay. And in those early weeks, what should he be doing?
What should he be doing?
Physio Mehmet has given his advice pre-surgery, and he's checked in on him, and he's now had his surgery.
Yeah. So
what should he be doing?
There's a very clear message: keep the hip calm. Like, so in those first few weeks, less is more, and it's really vital to really focus in those. And I would say probably to stretch it out into probably a 6-week period of just don't irritate it. Don't come out of that 6 weeks worse than you were before. Don't come out of those 6 weeks with an irritable hip. Take it easy. Sometimes harder to do that depending on certain situations. Sometimes different patients will do that better than others. Sometimes it doesn't feel too bad and then you've got to rein them in. So the message is don't irritate it, keep it calm. And then you almost like there'll be like specific objectives that I would want young me to focus on in that first phase. And a lot of that also is underpinned by the surgical procedure and the rationale behind why we would want to keep it calm and quiet and calm.
Young Charlie, if young Charlie was physioing young Mehmet,
Yes.
he'd have been in there like coming in, like squatting, we're hip thrusting, let's build this stuff up. The naive physio me was definitely overcooking stuff. You're in that phase as a new grad thinking, you just got to, well, certainly my mindset was we just got to build people up, we just got to get them nice and strong and help them recover. But these days it's the flip side, exactly what you just said. Yeah. I love hearing, when I speak to people about this, I love it when they are saying that stuff back, because you can't undo it. Once you've pissed it off, it's really, well, you can, but it takes ages.
Yeah.
It takes ages. So you can't really make your recovery in that phase, but you can certainly break it. So I think I agree, less is more.
Yeah, definitely.
Let that time happen. Let biology do its thing. So I say all the time.
I say that
let biology do its thing.
I say that too. Oh my God. Twiggins. Well,
so biology, let's say, because I knew young Mehmet when I was a young Charlie.
Yes.
And his hip was not a calm hip. So
no,
it flared up. You had a pretty angry hip flexor from memory.
Yes. Yeah. That was bad. I'd say that was probably my main problem for 2 years. And I remember conversation. It's weird how you don't remember much of certain things in your life, and you remember and I remember specific conversations you and I used to have about my inability to drive without pain, because I couldn't lift my leg up to use the clutch repeatedly, and it was just because that I couldn't lift it, and that was a real problem for me.
Why do you think that stirred up for you in particular?
Mate, my recovery was, I was the worst patient. Like I said earlier, I was at the time, I like what you said in regards to like how you would approach it. I was doing the same. Like I tried to do too much too soon. I was on it too much. The rehab I was doing was, I also think like I was in a period of time where our understanding of it back then was very different. You know, you got to think, what year was that anyway? Like
probably 2012, right? 2013.
So but considering the fact that we got the Warwick consensus on how to diagnose it 4 years after that, like we really didn't know much about.
The Hip Physio wasn't on Twitter.
No, there was nothing. There was hip specialists.
I don't think it's what Brad was about. So it just
there
wasn't even access to.
Yeah.
The CPD we have now online is so easy to access, right?
Different. Yeah, it's different. And I just I didn't know how to manage it. The physio input that I had was fairly poor, to the point of where, like, I remember going for an appointment in this Bupa clinic and the guy did a psoas release. Obviously at the time, I didn't know what was going on. I just thought, this is painful, and didn't do much. And all my treatment was the stuff that I think actually would have probably fit with how I would structure it now. And that's what irritated. I went to the Champions League final 2 weeks after my surgery and walked way too much up too many stairs. But if anyone loves football, you will take 2 years of playing for the Champions League finals.
Well, you also make bad choices when you're a patient as well.
Yeah.
Right? And I've been a patient a couple of times with injuries and surgeries. And that's why these days I'll outsource it to someone else, because no matter how much I know and how experienced I get, I'll still make bad choices as a patient.
Yeah.
And that's the thing. Patients will always make bad choices because they're too emotional about it. Or they're not too emotional, they are emotional, and that's their right to be. It's our job to understand the logic of it, the rationale, and help them make better choices.
Yeah, absolutely. When you said there about the first few weeks, the reason for that is if they understand the kind of surgery that they're having, it really makes a lot more sense. Because what happens is you don't see much for an arthroscopy, right? It's like way more impressive to have a knee replacement. This massive scar, right? It's way more impressive to have a hip replacement because you get this massive scar. It really is. No one gets their arthroscopy scars out at a party. There ain't much there. So you don't see what's going on. But then you say to them, look, actually, when you're in theatre, the position that you're in, the influence on your joint, the impact that it has on your stability, the proprioception, like a lot goes on that you have to get back before you want to do the stuff that you do, even if it feels good, because biology is biology. Like, it can only be so quick. Like, you just got to just wait. But what you said about it's won or lost, you're right, because people who have those irritable hips in those first weeks do struggle in the latter stages because you just waste time trying to fix the flare-up.
I think it's a really good point you make there about how it's very easily underestimated because of the tiny little keyhole marks. People think, it was just keyhole. And they say that all the time. It was just keyhole. It's like, yeah, you haven't seen what they did inside of that hip. Once you've been to see surgery, you see they're shaving off stuff, they're yanking it around, they're twisting things. Like, it's serious stuff that goes on, and it's easily underestimated. So I think it makes complete sense that, less is more in those early 6 weeks.
Yep.
Would you give them anything?
Yeah, definitely. I think that there's a couple of things that you need to consider. Like, first and foremost, we don't want it to stiffen up. We don't want them to become fearful of using either. So there's certain limits. Like, you want to keep the hip mobile, but you don't want to push it too much. You want to keep them active, but you don't want them to be too active. So sometimes, and a lot of this is sometimes governed by the surgeon's preference. Some surgeons will say, to get on a bike, static bike, ASAP. Some will say, wait a week. Some will say, use the hip within the ranges that are comfortable, but not to the end. Some will say, only get to 100 for the first 2 weeks. It varies. Surgical kind of like insight is important with that. But the goal is we don't want it to stiffen up. We don't want it to become irritable, and we don't want them to be really shit scared of using their hip. Because if you have 4, 5, 6 weeks, this is why I think sometimes it's challenging when it's a real kind of double-edged sword, because sometimes people have microfracture with this kind of procedure, right? And in those scenarios, their weight bearing is limited for 6 weeks. Now, if you have someone who is weight bearing limited for 6 weeks, you've taken that out of the equation. You've taken don't do too much out of the equation, because you're literally telling them you're not allowed to do it. But then it's the other end which gets worse, because then they're like so scared to do anything that they don't do anything. And you're like, well, weight bearing is one thing. Isometric activity is different. You doing stuff supine, short lever, long lever, standing, but like not weight bearing. There's actually a lot of stuff that you can do. Keeping the hip mobile, still not weight bearing. So like, there's always things that you can do. Your role is to kind of find, where's my pitch point for this person, for this kind of scenario. And I always urge physios, if you're going to treat someone, I don't care if it's week 1 or week 10, get their op note, because it's not the same for everyone. Like it literally the same on paper, FAI hip arthroscopy is not the same 10, 20 times over. You want to know the size of the cam, the type of repair. Is it a repair? Was it a resection? Was it a really unstable labrum? Were there cartilage defects? Like, you want to know this stuff. It might not, like, you could turn around and say, is it going to change what I do? Well, probably. It gives you more understanding, gives you more context to, is that why that patient's hip is more irritable afterwards? Is that why they're better afterwards? So it's just information that you can kind of govern to judge what you're going to do.
And the patient loves it. If the patient if you've got this op note and you're like, oh, I've seen your op note, I've seen the consultant letter.
Yeah.
Bloody love that stuff.
Because,
there's
care, I guess.
Yeah, it just shows that extra level of attention to detail for their case. And they just feel like, oh, everyone's working together.
Yeah.
Everyone's really, really in this for me.
Yeah, absolutely. On that point, I'm just mindful, sometimes people listen to this as physios and they're like, I want some nitty gritty, like actually tell me what to do. So I might as well is that all right?
I'll let you.
Okay, thanks, mate. So things that I find that work quite well, like 4-point kneeling exercises, you can do quite a lot on an operated hip. You're able to extend the hip into a range of movement that's not provocative. You're able to work in your rotational index without provoking it. You can actually do it in a fairly controlled way. You're able to do isometrics, both supine, adductors, abductors. I'm all about trying to get things active for that patient as much as possible, but also educating them on some other things, right? Because they might turn around and say to you, we're having this discussion with someone in the break about like upper body stuff. They'll say, okay, well, I'm going to not do much for that, but I'm going to go and do my upper body in the gym. And that's one of the other things that I was really like, honestly, I don't know how I survived this far in my career, but when I went to the gym and I was in upper body, like clever me, I'm just doing shoulder press, but actually I'm putting the dumbbells on my leg and pushing it up. I'm walking from the dumbbell rack, sick, right? And then I'm standing up doing upper body stuff for lats, rotating, twisting, putting it down, like the cumulative effect of all this stuff you don't think of. I'm doing lat pull downs, so my legs are like rigid underneath the thing and I'm like yanking it up, constantly isometrically flexing my hip. I'm doing my back. So I didn't have this support. So but when we're talking about prehab, I've dealt with this at prehab level. So this isn't new. That's why that side of things is also important. But these are like the really important wins that you've got to get in the early stage.
Cross transference. Are you worried about that? Getting the other leg.
Yeah.
Stay strong in the gym. Keep doing your leg press on the other side.
Always. It doesn't necessarily have to be leg press, but things like, a staggered single leg sit or staggered sit to stand using the good leg for sure. All of these things, there's always something that someone can do to help you create a plan.
Yeah, because that changed my practice, because I was seeing a load of post-ops at a previous job, and when I learned about that cross-transference effect, it's like, the body is just crazy. How the hell, I still don't fully understand it really, but it seems to work. So you train the other leg, you're getting 12 to 15% benefit on the operated side just by training the non-operated side.
It's also the same as when you're doing massage and then you do the wrong side.
It still works.
Still works.
Yeah.
I remember doing ultrasound when I first qualified and it wasn't even on. Still worked. Do you remember ultrasound? Do you remember that back in the day, ultrasound?
Yeah.
Is that still a thing? No. Okay. Fair.
Good. Thankfully. And when you've got cross transference, you've got upper body. You're telling them less is more. You've given them these 4-point kneeling exercises, some isometrics. They're starting to. Is there anything else in that?
Yeah, because we haven't spoken about our goal. Because our goal isn't those things. Our goal isn't just to keep it. Keeping it quiet is a requisite. Our goal is get you independent. Our goal is you walking up and down the stairs normally. Our goal is you being able to go to the toilet independently. Not having to kind of be too over relying on crutches for too long because you can't carry a tea into your front room. Like that gait and function is the initial goal. There is no point trying to build someone's stability and strength if they're not independent yet. So it's such a basic thing that you don't think about. Like, actually, can you walk up and downstairs with quality and with decent movement? Can you sit to stand with quality and decent movement? Are you able to walk and do things around the house with ease? Those are the key things that underpin the rest of the journey. There's no point going and just doing the isometrics and the range of movement if those things aren't improving at the same time. So it's a kind of to double-pronged approach with that. But that's the goal, that's the objective.
At which point would you expect someone to be walking without a limp, without crutches?
It depends how well. It's a classic physio. It depends on how severe the hip has been before, how long they've had symptoms, the degree of repair, what they've had.
Let me ask it a different way. At which point are you worried that someone is not walking without a limp with crutches?
For FAI,
yeah,
I'd probably say if you're like 2 months down the line and you're like requiring crutches, I'd say that is not normal. Mm-hmm. I was limping for 6 months.
Yeah.
So like it varies. If you're a patient who's had a severely arthritic hip for the last progressively worse over the last 3 years, you've waited on the NHS for 8 months to have it and you've just had it repaired, technically you're going to be limping for a little bit afterwards. You have to, because, and look, I think again, like if they know that, they can manage it. I always give the elbow analogy. Like everyone knows what a bicep does, right? But you need your elbow to let you do their bicep curl. Now, if my elbow was broken for 3 years and then one day someone just clicked their fingers and it was fixed, I'm not going to be able to do this because this would have shriveled up and it's going to be stiff. That's one movement. Imagine that like 8 times over in a weight-bearing joint. It's definitely going to take some time. So the kind of context is quite important with that. And again, if they know, then they're not going to look at themselves limping and thinking, oh my God, I'm really struggling. They'll say, okay, I get it. But that's why we have to try to facilitate the quality of movement. However, I am really, I'm almost like, so I had this conversation with a really well-known surgeon that I worked with, Prof. Griffin, 3 weeks ago, because he was like, I want the patient to be on 2 crutches and I don't want them to progress to 1. I just want them to be on 2 and then like, until it's perfect. I'm like, yeah, it's really hard to live your life on 2 for like months, like for 4, 5, 6 weeks. I was like, his concern was with 1, you'll limp more because you'll be off balance. My argument was, what if he's not? What if we actually could train him to walk better independently with 1 and coach to kind of segue? Ideally, we want no crutches. Like if we went from 2 to nothing and the quality was there, then it doesn't matter. So I think it's always like, sometimes in healthcare, we can get stuck in these real rigid frameworks. Because I said he was like, actually, you know what? This is the first time in ages anyone's ever just asked me like why we're doing it. He was like, and actually, I haven't had a conversation with the physio to kind of argue the other point. I was like, no, I'm not arguing with you.
But this is literally my point at the very beginning. We're in a different realm to the surgeon. Yeah. We have a different way of thinking about stuff. So we have to think about this hierarchy thing differently. But yeah, we are just specialists in different areas, and if we talk more, we learn off each other, challenge each other's preconceptions, and get better results.
Yeah, absolutely. I agree. So yeah, 2 months, I'd say I'd be worried if you're kind of like still really dependent on crutches at that point. 5, 6 weeks, I'd say you kind of in that area.
Relatively normal.
Oh, okay, yeah.
I'm thinking on a case that I had this year, similar to young Mehmet, is a bit
4 weeks actually. 6 weeks is actually probably, I've probably been a bit like too cautious there. Yeah, 4 weeks, sorry.
So I had a case, he was progressing really well. He wasn't limping anymore. This is probably 6 to 8 weeks in, and we started to do some mobility work with him. He was doing great, and he was doing like some internal rotation, and he had pain doing it. So we said, all right, well, for this week, let's just not go there and see what happens, and then we'll try again next week. Same again the next week. And I'm starting to think, he seems to be doing great. So I'm not really that worried about overall inflammation. I don't think he's in a bad place in his hip joint. I'm just wondering whether maybe he's just really sensitive there because he's been sensitive there for years. So we started to play around with some like graded exposure to it. And actually we did some manual therapy with this chap. And suddenly he had like 50% more internal rotation through one session of just doing a bit of it and then releasing stuff. Right. So this guy then has less pain, feels more confident about it. He then feels better and walks away and carries on with this exercise. And he couldn't believe that his problem was better that way, right? So I guess in one part of me bringing this up is that manual therapy can still be really effective in these cases at this stage, because some of their pain, like you said earlier, is not the joint, it's all the stuff around it, right? It's like the elbow metaphor you just used. Sometimes it's just really bloody tight muscles that are restricting. The other part of it is like, sometimes we don't know whether they're ready for stuff because they're in pain and we get a bit twitchy about it. And sure, I gave this guy a week and then we tried it the week after. I think sometimes we just have to go there a bit and test it.
With pain?
Yeah.
Yeah, but like,
just have to go there.
What's the worst that could happen? I mean, like, I think people are way more robust than I think we kind of give them credit for. Like, doing something like that in a sensible, structured remit is fine. Doing it, the patient doing it off their own back, just doing these 90-90s before having had surgery for a hip that doesn't move, like, makes no sense. So, like, in our situation, like, if he had surgery, right? Or she had surgery, yeah. So there shouldn't be a required, you know, if that hip has been assessed pre-op and it's been proven that there is impingement in these combined movements and there's been surgery to rectify that, you don't have that same catalyst of pain morphologically. So you kind of, you have the right to, if your person was saying that I've got restriction in internal rotation playing golf and I can't do that because of my AFL or whatever, and then they have the surgery, well, it shouldn't. Like, you've earned the right for it to be less of an issue.
And this is what I said. And he said, what about if it didn't work? And actually this comes back to your point about the surgeon, but because that's a reasonable argument. Mm-hmm. What if the surgeon didn't quite get the right outcome with what they were trying to do?
But you proved that it was.
Yeah, in this case it did. But sometimes the answer might be, actually, yeah, that's not quite right still.
But your improvement in one session by that much validates your point.
Yeah, because for this particular case.
For this case, yeah. Whereas where it might not, and I'll give you like, so I'll give you an example of like when I'm concerned where it's not, just because I know we're going to go into like management, which kind of this feeds into this like maybe like impaired outcome management. Your patient will have your list of things that provoke their pain that you've logged from that first appointment. And whether I'm managing someone before they've had surgery or conservatively, or whether I'm managing them after surgery, every time someone comes, and this is just my habit, I don't know why, but I just kind of, this is just how I do it. And this isn't right or wrong, but like if someone comes back, their appointment, they're saying, oh, I feel better. Like actually the exercises are getting stronger. I'm feeling better. I'm feeling more mobile. We'll have that win and we'll enjoy it. But then I'll always say in that appointment, I'll say, you know what, look, can we just reference back when you came the first time and let's be really critical of the things that aren't improving. So we know where to put our focus on. It's great that this has helped, but then and as you go through it, it's also another nice win because then they'll say, oh yeah, that's easier. That's easier. That's easier. And then you're left with like maybe one or two things, which is your focus. And then that can underpin some of the other stuff that you're going to do. But if they're not getting any better, you're referencing back to that thing before. And actually, it still hurts when I sit, when I walk. And yes, they got stronger because they've done the exercises, but the actual tangible thing that they couldn't do hasn't changed. If they've had surgery and later down the line, it's looking exactly the same as it did before, then you're kind of thinking, well, that's different to this one movement. This is like, actually, it hurts when you're sitting, which was like the main protagonist for your symptoms in the first instance anyway. So like, it's always...
What do you do then?
Well, first and foremost, I see what surgeon they had, really, just to kind of understand that. I would make sure if that's my patient and I hadn't seen them before, like give them time. So as an example, the one who is on the back of my mind, just because I'd seen her this week, has been rehabbing it post-operatively for a year. And as of last week, this is painful and her Fadirs is painful. These are limited clinical tests, but flexing your knee to your chest shouldn't be reproducing the same pain as you had before the surgery when you've done a year's worth of rehab. So if I'm thinking why I got at that point, my job is then I need to kind of prove why that is. And that's when you would then revert back to the surgeon, you would get updated imaging, and then you would kind of compare the things that are being treated and to see if there's any issues that have arisen as a result of that. That's different, obviously, if this was painful week one, because it probably would be a bit sore. So does that make sense?
Yeah. So young Mehmet this time around has done his early stage rehab a little better and he's kept things calm. Biology's doing its thing and he's settled down into a decent rhythm. Life's fine. He's walking fine. He's going up and down the stairs. He's keen to get a move on now. Mm-hmm. So what's next on the menu?
Next, we've got this, like, we've got to build the stability of the hip, right? So we alluded to it slightly in the first section. You got to get into the hip joint. This is how I educate my patients. I'll say to them, look, this is obviously from before. You got your socket and you got the ball in the socket. They're bone, right? So you got ball and socket. And then you got this thing on the outside called the labrum. That's what's obviously been giving you the grief. That kind of makes the socket a bit deeper and suctions the ball into it. But what it does is it gives it additional amount of stability, essentially, kind of allows it to be congruent. Now, that's not enough. You've got the ligaments that surround all of that stuff. That is the joint capsule. And all of these 3 ligaments will do something slightly different. They are going to restrict your hip into going into excessive ranges. That helps your stability. Now, your cam and your labrum is essentially covered by this stuff. And so for your surgeon to get to where you've had your surgery, they got to somehow go through that ligament. No one's ligament was ever stronger after someone cut it. So we have to kind of consider that. Now, if your surgeon accessed the joint through the ligament, that ball is still going to be absolutely rock solid into that joint. You can't get to what you need to do. So they distract it by about 8-10 millimeters. And to do that, you need a machine that will distract the joint. The reason I'm telling them this is you don't see this. And all of this stuff is going to impact how the joint moves afterwards. So even though your pain might have settled down, we've got through the first 4 or 5 weeks and you're walking better and you're standing up and you're doing all that, it's healed, but you sure as hell haven't resolved all the influence of the surgical procedure. So now we need to build that. We need to build that deep joint stability and all the stuff around it. And that's where the exercises come in. Now, stability isn't just standing on a Bosu ball. Bosu balls are great, but like you can't just stand on a wobble cushion and think that's stability. You got to think, what are all the things around the joint that give it stability? What do the muscles do? What do the anterior hip do? The glutes, the adductors, everything has a component of stability, because outside of that capsule, that's the last line of defense. So that's the focus. This stability phase is where everything now, really, the objective and the goal is, are you going to be able to tolerate the sexy strength stuff when we get to it in the gym? But you've got to earn the right to do that by doing this stuff. And you can only do that by kind of putting that little focus on.
Give me some examples of some of those types of exercises.
Nice question, Jazz. Thanks. So I love doing things in prone. So I think we're really used to just doing things standing up, doing things getting on your back and things like that. I love doing things in prone. One, I think the abdominals and the lower abdominals around the pelvic girdle are unsung heroes of hip rehab. So things, I'm going to reel out some exercises just that are in my head, and then you can ask me if you've got any questions, and then we'll just kind of explain it. So things like plank, abductor sliders. I love sliders. I literally tell patients, I'm like, if you haven't got sliders, go and buy sliders.
We're talking sliders as in
not flip-flops.
Not the flip-flop ones.
Not flip-flops.
Right,
Yeah, no one's yet to come back into their appointment with a set of flip-flops.
Got the sliders.
Dior ones from Love Island. No, none of them. So like circle flip for Amazon, £5, bargain. Prone abductor sliders works on anterior stability isometrically. You can go into a lateral movement. It's great. It's often non-provocative. If they haven't been flexing their hip, you've got to earn the right to be able to get them to concentrically flex the hip. So I normally use the sliders to reintroduce things like knee tucks, like mini knee tucks, bilateral. You could do it on a Swiss ball as well. Single leg modified mountain climber sliders. Again, the purpose of that is we've got static compression there for that anterior stability. You've got everything around the other 3 quadrants essentially also supporting, and we're able to just control and almost like mitigate the range and progress it as we need. All of these things that you would do in prone will then hopefully build up your hips capability to flex better concentrically, because we're essentially trying to do it also from the trunk, especially with like the knee tucks and the Swiss ball pikes, which are hard, but often they can do it and it's not provocative. Obviously, anything single leg that will help with stability, especially with deep stabilizers, are far more better utilized to do things like step up type movements. So when you're doing something as basic as a step up, off a box, plyo box, even a footstool, one, it fires up your deep rotators way better than you would do doing kind of just isolated rotational movements. But then it starts to function your adductors. in a different way to what you would normally think that they work. So you're thinking about all these different, the versatility of all these different muscles and how they can support joint stability globally, rather than just saying, I'll stand on an unstable surface, you know, and the list goes on. Like you could do a short lever side plank with 2 legs with your knees bent, potentially could be okay. You could progress to 1 leg. I tell you what you wouldn't do is you wouldn't do clamshells. And I'll explain why.
Beat me to it
if you want me to, because I could see you're like
primed for that one.
Yeah.
Okay, go on.
They're not bad. Like if you have no hip pain, I don't care if you do 1,000,000 clamshells. Like I really don't care. But when your sideline and a flexed hip is flexed and you're externally rotating your hip, your iliopsoas is just constantly translating around the front of the hip. And if your anterior capsule is irritable and you've had surgery, or even if you've just had FAI anyway, that's provocative. And you're doing that normally with the thought that it's activating your glute med, but when it's not. When your hip is flexed, your glute med acts as an internal rotator. So actually, whether you've got lateral hip pain and you're doing a clamshell, it will provoke your glute tendon attachment. And whether you've got an anterior hip issue and you're doing a clamshell, it doesn't really do much. There's less value and actually more risk of it hurting. Doing a side plank with 2 legs or even a short lever hip abduction will do way better. And then often in those scenarios, I play around with 3 things. And this is kind of when I start to replicate a similar approach to how I manage things conservatively. Angle, dose, resistance. So angle is everything we do with the hips. With this, to be honest, with most stuff with hips, is an angle. We need to just manage angles, right? And if you're limited angles in one capacity, you can play around with dose and resistance, but you're not going to make the angles harder and give more dose and make more resistance.
Change one thing at a time.
So yeah, that's kind of the principles that I tend to follow. And this is in this phase with stability, especially with like deflection and a rotation, where I start to just almost utilize that framework a little bit more.
And you've got a pretty stable, or you're developing some stability there in safe positions. You're managing angles. What progressions do you have for those? Because they'll hit that mid phase and you'll start to increase the stability demand.
Yeah.
So how do you then progress? If we stick to stability for now.
Well, look, you know how with the first one we said like we almost had like our criteria, right? Our criteria was you got to be independent. You had to sit on the toilet, wipe your bum, stand up, walk. Our criteria now is, what do I need to do to allow me to go and do the strength stuff in the gym? And that is essentially having a hip that has function, having a hip that moves, and having the hip that can control what you're about to do. So you shouldn't be going into doing deep squats and lunges and deadlifts and all that kind of stuff if you've got a hip that's like really restricted still, or have ranges of movement that haven't been addressed. So like what you were saying there with like the range of movement, passive stuff, the treat hands-on stuff, like all of that stuff will facilitate you having a hip that can tolerate what you're going to put it through. But one of the most common coexisting musculoskeletal complaints that people have with hip pain of any nature is often lower back involvement as well. If you've got lower back pain, it's mostly because something isn't quite doing its job, and it's probably an overload in your back. If you've got some of the key, you look at people preoperatively, some of the key things that they struggle to do is lumbo-pelvic dissociation. And I give the shitting dog analogy, where you ask them to go from an anterior tilt to a posterior tilt, and they look like they're your dog when they're having a poo, because all they're doing is this weird hunchback thing and everything is moving. And I had it with a patient today and I filmed it. I didn't describe it as a shitting dog because I have a degree of professionalism in my appointments. But I said, oh, look, remember when I asked you to do this? And I did it because now I'm really good at it. And I said, this is how yours looked. And he was like, oh yeah, that's not the same. So it was just that kind of, and that those things you got to almost like clean out behaviorally so that you're like optimizing afterwards. I just want every step to be smooth, and you got to kind of earn the right to progress it. So the timelines are there, but it's very much like fluid to what their like progressions are like.
I'm working on a hip case at the moment who came to me originally maybe 3 years ago with kind of vague, at one point we weren't even sure whether it was radicular, whether it was hip joint. In the end, rehab kind of went well, then it stopped going well and it got worse again. And we said, okay, I think you need to go and get some imaging on it. He went to get some. He went to a consultant, had imaging, was set up to have FAI surgery. Turned out he had this big cam, and that was almost certainly his problem. He then had a massive ski accident and like broke a load of bones, and we spent a year, maybe a year and a half, rehabilitating him from that. And then all that got better, remarkably, because it was horrendous. Actually, he did incredibly well. And the one thing left was his bloody hip pain again. So he then ended up having this hip surgery. He's now coming out the other end of that. He's maybe a few months post-op now, doing really well. And his back pain came back. His kind of back, radicular pain came back. And he's obviously getting frustrated, understandably. He's like, God, it's just constant, isn't it? I've had like such a shit 3 years. Like, yeah, look, I totally understand it. Let's go back to basics. I looked at him walking down, like a step down, and his pelvis just shifts out. Steps down, pelvis shifts out. And I videoed him doing it. It's like, I can't believe that we're at this stage and this is what we're seeing, but this is why your back hurts, because you still haven't developed that stability around your hip. We've done all this other work, like he's had forearm stuff, he's had back, and yet here we are, like 3 years later, we're probably back to the same point. But at least now your hip joint isn't the problem.
Yeah.
Right. So because we got to the point where actually developed quite good stability with the limited range he had, but his hip pain was still there, and now he's come back out of the surgery. The back pain, the hip pains come back, but it's not for the same reason.
It's the difference.
It's now the movement dysfunction.
And I think they don't see the fact that like these things are, pathologically, it's not going to be like that is causing your back pain. It's that is causing your back pain, but in a different way.
It's a compensation pattern.
Because they think it's like referred pain. Sometimes it's not. It's that. But interesting, seeing as you keep talking about young Mehmet, right? Do you remember what I injured before I had my hip surgery?
Your back.
My back. Yeah. Do you remember when I was there, how I was doing it? We're doing deadlifts. And I remember I was in the gym doing deadlifts. Like, I think it's like 350 kg or something, is it? Why is everyone laughing at that?
Decimal place, I think, is in the wrong bit.
Yeah, 30 kilogram deadlifts. And I remember like my back was wrecked. And I always had some stuff on and off as a result after that. And to think that I had this done, and years later, 6 years ago, I had spinal surgery for radiculopathy of a really screwed up disc on this side. You never quite know, like actually had that occurred because I was so impaired movement wise from my hip that when I was doing deadlifts meant I moved differently. Obviously I probably wasn't training well. And then you never know, like I could never prove that. If I went to the judge, court adjourned, but like, you never know.
But sometimes it's helpful for the client for you to make those connections with them. So we don't know for sure, but there's a good chance that this means this, means this, means this.
It makes sense though. It makes way more sense than you saying, I think your hip is causing your neck pain.
Yeah, you can make a leap. You can make that leap.
Yeah, right. Or like your tennis elbow is probably not because of your labral tear.
Yeah,
but your back might be.
Yeah. So in this situation, then you've got young Mehmet is developing this hip stability. He's looking pretty solid now. He can step down, and the stability looks good. He can do all his slider exercises. You're in the gym. He's earned the right. You keep using that phrase. I like it as well. He's earned the right to be in the gym. How do you get him started in the gym?
So this is when we can have fun. I mean, the other stuff is good, but like,
nah, don't. Rehab's boring. Everyone knows rehab's boring. I say this to my clients all the time. Like, look, rehab's really boring. We want to get you out of this phase. You don't have to do this forever.
It is.
So you've got to do it. You've got to earn the right, as we keep saying.
It's a bit boring, isn't it?
But let's get to the fun stuff.
It is.
And that's for some people, it's the gym. For some people, it's Pilates. For some people, it's going for a run. But it's like, let's get to that fun stuff.
Yeah, I agree. It is what they want to do. Look, we're still considering the fact that probably the most useful research paper that we've had for managing FAI in a physical rehab context was published 3 weeks ago. Says it all. Because everything that we're doing for as long as we've done it, and also that's one paper. Oh, it's great, but like, let's just be realistic. It's one paper, right? Yeah. We still have this like gap of what is the best for this kind of stuff. So when we're getting that patient into that phase of strengthening them in the gym, we have to make it so bespoke for that person. We need to make it bespoke for the way their hip moves. Their angles will be different from one to the other. and then we need to make it specific to what is the whole point of why that person's had that surgery. And sometimes they've got sporting goals, right? And you've got to start to consider that. But if you then start off in the gym straight away and you just go straight for like the stuff that you think is going to be good, get them on a like leg press or a hack squat or a deadlift, we haven't really made that asymmetrical, whatever you want to call it. We haven't addressed that. So the goal really is to try to segue into those things, to be able to kind of get them to do the compound double leg exercises effectively. So I tend to focus as much as I can do to still put a little bit more focus on the operated side within limits. And that rehab plan is then going to look different. So the structure of it then starts to take a little bit more focus, as now you're in the gym, this is now like the only leg stuff that I want you to do. And I want you to do this every other day if you can. But ideally, my kind of sweet spot is if you could do it 3 times a week, I want you to do it 3 times a week. And if you're going to go into the gym and you're going to do this rehab, I want you to make it count. And I'm really specific with like the volume, because obviously that's one of our metrics of what we try to kind of modify or manage. And then I'll give them the criteria of specific circumstances to make them autonomous to their care, right? So I'll say, look, this is now your plan. In reality, I'd probably say for 3 or 4 weeks. You don't need to chop and change stuff. Like they need to just, if they can't do it today, they're not going to do it next week any better. Like they'll be a bit better, but like no one goes to the gym and expects a change in 3 sessions. So you've got to give it time to breathe. So consistency is king for me with this stuff. But like if there is gaps in between, 1, they can observe their response. 2, if they've got a flare up, they've got time to manage it. 3, if you've got 3 sessions a week, it's way more feasible to do that than every day. 4, if that session is taking half an hour, that's way more feasible to do than an hour session. And 5, well, there was 4 points, but 5 sounded good to make a 5th point. But anyway, those are the 4 main points I was kind of focusing on. But if you can get them to give them the key things to consider if it does flare up, this is what you do. Because patients freak out, right? If something goes wrong a little bit, or they get a little bit of pain, they freak out. First thing they're going to do is like, oh my God, I'm going to email them. And like, honestly, it's annoying. Like you don't want patients emailing you all the time, but sometimes it's okay. So I tell them when you're allowed to do it. And I'm like, look, if you do this and you're like, this is your set 1, right? And look, their exercise, let's just kind of hypothetically say, right, you're doing a split squat variation. You're doing a higher step up with a contralateral load. I've got you maybe we're doing like a Copenhagen or something. And we've got like, this is your plan now. And this is your strategy. If you do session 1 and session 2, and then after that, you've like got a bit of pain, don't email me. Like just have a few days rest, let it settle down, do it again, do exactly the same thing again, and then see your changes and the response exactly the same. Because we don't have control of every variable that causes someone to have pain. There's loads of context to that. So I'll say, if it happens again, I still don't want you to email me. I want you to do the same thing, but I want you to do half the amount of reps and sets that you were doing. And if it then happens again, then I'll open your email. Then you can email me and say, look, I've tried to manage it and I'm struggling. But like, if you email me after that 1 session and it's happened, this is exactly what I'm going to tell you to do. So like, just try and be a little bit like, and that's me being hard cop at this stage. Now this is me just trying to build their self-resilience a little bit, but in a very clear understanding of like, I am there to support you, but I'm not there to hold your hand like you are a grown up. Like there's a level of like, you got to just be a bit more like, what's the words?
Ultimately, this is the Physio Coach Podcast, and you're being a coach. You're helping them.
You're so profound.
You're helping them figure out their own shit.
Yeah,
like exactly. In that moment, it's really powerful for them to go, oh, you said about this. Oh, you said I might get a flare up. I'm just going to see how it goes. I've rested a few days and I'll try again. Oh, you said about, even the second time, you said about, I've just reduced the load. Can I tell you how I've learned that? I've learned that the hard way. And I think it's worth people like hearing the good and the bad from how I've developed and learned. And this happened a few years back, right? And this was one patient scenario, changed my practice with this kind of stuff. It's probably a few years back now. And this patient had a really complex history, like really convoluted physical and psychological history, right? And I thought
we had a really good appointment. But that whole hour was talking. I didn't do any because I couldn't get to it. Because actually it was like such value in the stuff that we were discussing. And I was trying to, years of stuff I'm picking. And I thought like, you know what, like I've done well with that. And I said to the patient, I was like, look, you know what, we'll have to just continue this. We'll have to have another appointment just for me to kind of obviously, we'll kind of go through things. And left it at that. And then I got an email from the patient. The patient was like, well, I don't even think she said thank you, but she was just like, oh, just to let you know, like, I'm really disappointed that our session ended when it did. I presume from our appointment, I would have had like a rehab plan, and it says from the booking form that we'll do like a thorough evaluation and a physical examination. And obviously we didn't do that. I'm really disappointed. Can you give me a refund? So my first reaction, I won't say, but then I genuinely was gutted, like, because like I'm completely I wear my heart on my sleeve, like, anyway, like, so what you see is what you get. Like, I was really gutted. Like, I was like I don't like getting in trouble. I was like, oh shit, like someone's telling me off. I was like, felt really bad. And then I thought, hang on a minute, that's fucking so good. Like, and you have no idea. So I thought, what could I have done better? And that was, I could have been really clear with the expectations of like what I communicated as to like why that session was the way it was. And off the back of that, it's enabled me to communicate things a lot clearer to a patient, to set those expectations, but also to set those boundaries from what is available from me outside of appointments as well. So it kind of like evolved into that, because then I realized sometimes patients would email me, and because of that, I was like, oh my God, I need to reply to everyone because I don't want to get like a bad review. I don't want to get like told off again. And I thought, actually, you know what? Like, I've earned the right with my career to get to a point where I'm like, I can't feasibly reply to everyone how I want to the second you email me. And if they know that in a like, you know, and I mean this in a professional way, like if they know that, then does that make sense? Sorry, I've asked you a question, and I'm also going to interrupt just before you do talk, because you're going to say something really profound in a sec. But like, you wouldn't do that to your surgeon, and you wouldn't do that to your dentist. You wouldn't even do it to your bloody vet if you've got an animal. So do you know what I mean? So that with physio, you mentioned the hierarchy. Anyway, I'll shut up now.
And I think what you're not saying is don't email me, because at times we do spend so much time with our clients, and there needs to be some level of in between contact, and we can set boundaries the way we think personally it's right for us. You know, some physios don't want any, and some are probably old you where you give everything. I think somewhere in the middle is good.
Absolutely.
And I think the better we get at coaching, the less they actually need us, because you're helping them solve their own problems.
Absolutely.
Can I offer something that I think helps in those situations where you're chatting the entire hour?
Yeah.
Halfway through, when I can sense they're talkers, I'll say, look, we've got two choices here. We can either spend the session talking the whole time because this sounds like a lot of your story, or we can cut some of this off now and start with some examination and then maybe pick it up in the next session. What would you prefer?
And give them the choice.
Because at that point, they get to choose.
Absolutely.
Because then they can't then come back to you and go,
you've fired me off.
Yeah, because they've chosen it, right?
Yeah, absolutely. And that's a really important point, I think, for younger physios to really learn from, because I think there is always that burden as a younger physio to, you kind of come out of uni and it's almost like subjective 10 minutes. I've got physical this much, I've got the treatment for that bit, and I've got my notes. And like, you're just stuck in that burden of like, oh my God, they're talking too much. Or like, sometimes it's the opposite. Sometimes they don't talk at all. And you're like, oh my God, like, I don't know enough because they're not telling me everything I need to know. So yeah, it comes with time and experience, I guess.
When's young Mehmet allowed to run?
Young Mehmet is allowed to run when, so you know what we spoke about earlier, I was like, some people don't need everything tested, right? If you're having surgery for this kind of condition and you want to get back to sport, the overlap between how you start to manage this like you would do at a latter stage conservatively starts to rear its head in this strength phase that I call it. Now, realistically, for the general population, even if they're a high level performance individual, I would say that strength phase, you're kind of looking at like probably starting it for me anyway, I'd say probably you're like at around 12 weeks, right? Now, if you're starting your strength stuff at 12 weeks, how long is it going to take someone to go through a full strengthening program for the hip? It's probably going to take a few months, right? Now, you then need at that point to kind of figure out, well, where our focus is going to be. And that's when you probably would start to get, and I think that's probably when you would probably start to get better data, because if you're testing them with your vault kit, like in phase 1, it'll all be all over the place. Now the pain is gone, their function is better, they probably just need a bit of guidance for their rehab prescription. Then you can start to take some data, maybe even compare it to what you took pre-operatively. Then at that phase, you're then thinking, right, I've got some objectives that I'm working towards. Now, before I can get them to run, they've got to prove to me that they can tolerate running. And that last phase is the dynamic phase. That dynamic phase embodies everything to do with force production, landing tolerance, change of direction, hopping, jumping, and all the nice things that you get with something that's almost like plyometric driven. And you could also, we've got, I know, like, don't get me wrong, I know not everyone's got access to like force plates and things like that, but you don't need it all the time. Like, it's no different to outsourcing that to seeing a sports physio to support with that, like you would do with someone with an injection. Like, it's still important information. You can still do the rehab and revert back to that to kind of get those guidances. But I want to make sure for this phase, there's 2 objectives. Can you physically tolerate doing running?
Not quite sure it works, but we'll go with it.
Yeah. May have cut that one out, bro. Can you tolerate
running?
And when you go running, is all you're going to think about, does it hurt? 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 Because you've not done anything to contribute towards you thinking that you can tolerate it. If you spend 2 months worth of doing progressive plyometric type rehab, and then you go for a jog, you've done way harder stuff than going for a jog, and you've been fine. So you're not going to go for a jog and think, bloody, I'm knackered. Like, you're not going to go for a jog and think, oh my God, am I going to tolerate it? So you're almost like back to building the physical and psychological resilience together for that phase. But I don't know if you realized, that's also underpinned every other phase, with the one way of trying to stop them from being fearful in the early stages. We're trying to stop it from flaring up and showing them that they can do stuff in the other one. Like, so everything that I do on the surface looks physical. And I would say currently also the way that I work, there is so much beneath that is psychology. And I think the better we are at intertwining these things as physios, the better the outcomes for patients. Because ultimately, like, and this sounds like something you'd say, we're dealing with people who have hip pain. We're not dealing with an FAI. We're dealing with like Charlie who has hip pain, Mehmet who has hip pain. And the thing with that is, like, this is different for all of us, even though this might be the same problem. So like, it's a coaching thing, like you said. And I think that's why I do believe we sometimes, as physios, because physios are not businessmen and women, right? We're not trained to that. We're trained as physios, right? So what's the most awkward thing for a physio to do when they're a little bit younger as well is, oh my God, I need to kind of keep booking you back in. Oh my God, like, they're going to think I'm trying to steal their money. No, like, actually, you'll be selling them a disservice if you don't treat them enough and then they don't get any better. That's what they'll remember. So like, we need to be really confident at just saying, look, you need treatment, like, you need appointments, you need to come back. Like, this is the time and effort that you need to do that. And when there are psychological components to their care, like, that's easier to support with when you're with them a little bit more.
There was a big shift in my thinking about this maybe 7-8 years ago, when I always got a bit icky about sales as well. It's like, oh, I don't know.
Is it like it's mentioned in the word? Like,
I don't want to sell people stuff. I'll just be a physio. And then I think that was coming from companies where they were like analyzing your numbers in a way that was like, oh, you're over treating because you should be getting rid of people between 4 and 6 sessions or whatever else. I think NHS can be like this at times, and certainly other cheaper insurers, they're often quite hot on these numbers, right? But in the other way. Whereas for me, I'm thinking nowadays, it's like, how can I keep adding value to this person's journey? And it's sales, yeah, but I'm selling myself as the best person for their journey.
Yeah.
I believe that I'm good enough to help this person. Therefore, that's sales, but in a good way. It's like, I don't want you going anywhere else. I'd rather you come and see me. I mean, maybe you'd be all right, but you know, I'm thinking,
it's true,
how can I convince this person that I'm the best person for the job?
Yeah. And I just always think about other healthcare professionals. Like, I went to the dentist the other month. Honestly, rinse me. Like, but I was just like, she was just like, you need this, this, and this. I was like, all right.
Yeah.
You've said that. Like, I have no idea. Like, I presume I do need all that stuff.
I probably didn't even educate you.
And I didn't go, you know what, actually, I'm going to go elsewhere. Like, because I'm like, you're a dentist. Like, and so we're so different though. I think like physios, we're so, but considering the fact that I'm really so lucky that I get to teach around the world, I see physios in like most countries, obviously, that I do my course in. And we are like miles above any other country. I haven't been to Australia. I think they're pretty good as well, but like incomparable to Europe, like loads of physios in their countries, it's illegal to diagnose. You can't even say, oh, I think this is your diagnosis, because it's like, you'll be like sued. So like the quality that we have in the UK and the caliber of physios is honestly like miles better than so many other places around the world. We should be charging, and we should be on that hierarchy miles away from where we are. And the sooner more physios do that, the better. Like, don't be scared. So I saw someone online, right? He put his price list up on Instagram. I saw he put his, and it was like £5 more. He was like, I'm really sorry, just because of inflation. I said to him, I commented, I was like, don't apologize for like you just charging what you want to charge. Whoever wants to come and see you will come and see you, and they will pay that, and they'll pay double if you're good. Like, don't be scared to charge your worth. But with physio, we're just like, this is our price point. And like, yeah, if you're in London, there's a little bit more. If you're like, charge your work. We're so good. Like, yeah.
Let's stick there for a bit.
Yeah.
The business side of it, because it's true that we don't get taught this stuff, and we have to, we're either a bit shy about it, or we've got to learn it separately. And you've come from working for companies, being in leadership positions, working in sport for a bit. Then you had a course, and then you started doing some Instagram stuff, and then you're an influencer. But you, up until relatively recently, you're doing all sorts of shit, right? So you're now running a business, let's say, right? How did that transition happen for you when you realized there was a bit more to what you wanted to do than just treating hips?
Yeah. I love, because it is, you're right. Like, so for me, the Hip Physio is a brand. It's my business, like, identity. It's a brand that built gradually, right, over a period of time. But my knowledge of operating a business before, like in the early stages, was non-existent. Like you say, we have no idea how to operate a business. And it isn't like what I've come to realize even in like more like recent times, in particular, like this last year, where it's almost like my whole livelihood is now my own business, is like, that isn't something when you discuss it as an achievement that, like, I think sometimes people see it as like, oh, you know, it's not gloating. It's like actually like trying to show that this is doable in so many different frameworks. And there is so much more to physio than just doing clinic. Like, you will literally burn yourself out if you're doing 40 hours. Like now, my average of clinic time is probably like 25 to 30. Like, if I had to do 40 hours in, like I was doing in primary care, oh my God, I'd literally cry. Like, if I had to do that all the time. Like, but sometimes there's no other option, like, because you've got to earn your living. You've got to pay your mortgage and do whatever. So what I found is I hit a point in my career, probably, I would say 7 years ago, where it was like, do I specialize more clinically, or do I try and do some more managerial? And I went down the managerial route, and for me it was great, because I was at that point, I was like, I'm getting really bored of just doing clinic stuff all the time. And I think the second I get the itch, I'm like, I can't fake it. Like, I need to like just do something a bit different. So I went into physio manager roles, clinical lead roles, and then up until last year, I was the head of a region. Like, I was in a company, a quite large company, doing a regional leadership role, doing a really small amount of work in primary care as an advanced practitioner. But I was responsible for like 100 members of a team, with a senior leadership team that basically did all the hard work. I didn't really have to do much, but like I had a whole leadership team that like worked with me. And so I had almost like the best part of a decade getting really good at managing other people's business. And I was like, actually, I've got skills now to understand profit and loss. I've got understanding of how to operate a business. I've got understanding of how to manage staff. Obviously now I'm never going to have any staff because like good luck, but like I'm all right. I can just about manage myself. But like I've taken those skills and then I've thought, actually, you know what? Like there's things that I can layer to my business model that I can utilize the skills that I've learned from that. So sometimes patients, get to that point and they think, oh, I'm in a physio manager's role. Right, that's my job for the next 30 years. I've got nowhere else to go. No, use those skills and try and finesse some of the other stuff that you're doing. And it is scary, like going from employed work to self-employed work. But you just have to, if you've got one of the, and we talk about it as well, like business mentors and business support. Like if you've got people that have walked the walk, like use them to support you and guide you. Don't try and reinvent the wheel. Just try and learn from them and think like, how can my life be more flexible with a better quality of life, still being a physio, but just doing different things. And there are loads of things, there is coaching models. Like you go online and you look at most of the things that you'll come across, you're not shy to find online fitness coaches, online weight loss coaches, online transformation coaches that I tell you what are getting paid way more than physios are, but their business model has enabled them to do that. We are so good at what we do. It's just trying to reframe the ways that you do it. And that's kind of where my focus, well, certainly last year has been specifically around that and just the different avenues of what my week looks like now, pretty much.
Thank you, young Mehmet. Thank you, slightly
definitely older after this,
less young Mehmet. And I really appreciate your time and your insights and your vulnerability about your own journey there, because it's really helped to anchor the episode here. You no doubt know the next part of this podcast, which is to ask, what does better never ends mean to you? And I love how I've spoken about this stuff to you loads of times because that's my little catchphrase, but I don't think I've ever heard your version of it, so I'm quite excited to hear.
Well, I from my perspective, obviously, like I remember you saying this when you were kind of creating this business, and I knew your insight, and I think we shared it, which was like, there's always that ability to strive for, I say success, but like success isn't only your own. Success is for the individual that's either working with you, they're working like alongside you, or the people that you're seeing and treating. And that's by just being able to show them that like boundaries can be pushed. And sometimes those boundaries are clinical outcomes. Sometimes those boundaries are personal. Sometimes they're business. And I think knowing you, and thank you, by the way, for having me on. I should have probably said thank you first, but yeah, thank you for having me on. I think knowing this kind of like question, it's always just about not staying here and being a plodder, which sometimes can be the case, and just trying to like really optimize whatever it is that you're kind of like doing, whether it's personal, clinical, or supporting patients. Yeah.
And I think you've got this kind of little startup Instagram account on the side.
A little side hustle. Really.
Yeah. How else might someone get in touch with you? If someone's interested in what you've said today?
Definitely not email. I would say if you are, I always welcome. I'm joking. I do get paid. I like talking to people. I like talking to physios. I like physios coming and shadowing with me. I like physios emailing me about their cases. I like physios coming to see their patients with me. So my website is basically just the easiest way to do it. So like the hipphysio.com, and then like you could just go and find anything you need to from there, whether it's like for a patient, whether it's my online stuff, courses. That would be the main route. And thanks.
Thanks very much for your time. And we're just going to open out a Q&A to the audience at this point.
Perfect. Thank you both for that. I think the question for me is, you referred to the term stability quite a lot in terms of the rehab model, and obviously talking about strength as well. What are your thoughts in terms of like strength and stability and how they kind of like coexist, or whether it's two different points in terms of your like philosophy or strategy for the rehab?
Yeah, I think it's a great question. They will for sure like overlap. I think when I use, and this is something that's quite important to also consider when you're discussing with patients, because if they hear the word unstable or instability, they always think it's worse than it is. When I utilize the word stability, I'm talking mainly from a like deep joint control component to it, right? And with that, you're right. As you're kind of improving that, technically you are strengthening things, etc. When we're at the latter stage of talking about actually like strengthening in that strength phase, it's much more around that, talking about, we were just saying like that's when you can take the data, that's when you can see those improvements and see those changes, where it's a little bit more tangible. From a stability perspective, those tangible outcomes are way more kind of like functional from kind of their response, and sometimes more challenging to measure because you can't, like, you're not going to be able to. But it's about trying to kind of consider the fact of like, why are we trying to do it? Well, we're trying to do it to kind of allow the joint to tolerate whatever it is that we're doing. But the argument is there, in order to do that, you're doing exercises. So technically, you're strengthening it, but it's just the way that you structure it for that context will be slightly different for each one. What you wouldn't want to do is say, like, if you're in that early phase, for example, with the post-op, we'll get the stability better by doing the strength stuff, because it's just that's when the kind of thing, the kind of process will probably go flat a little bit. That's a great question. Oh, go on.
Yeah, I love that question, because I think it's important that you differentiate, because for me, you could be strong and not stable, and you could be stable and not strong. And that's what you have to be trying to figure out with this person in front of you. Which are you? I mean, they might be lucky and be both, but there's a good chance that they're one or the other. And the strength is something that they will develop from a capacity perspective over time. The stability is the skill they have to learn. They've got to learn this neuromuscular skill that's ultimately comes from the brain. And that stuff can happen in the moment. They can literally develop that skill there and then. Whereas strength often, unless there's this kind of like neuromuscular activation side of it, strength has to be developed gradually over time with persistent overload, consistency and all that. So that's how I would separate it with the two.
The floodgates have opened. This is good.
I have a question for long-term management. So if you have a patient who has FAI, maybe had a surgery, maybe didn't, but you've managed them in that moment and they're coping fine, especially if it's a female in their early 20s, when it comes to things like pregnancy, later on down the line, maybe put on a little bit of weight, maybe your hormones change, perimenopause, all that fun stuff that happens. What's your advice around managing that long term if you have those issues? Because it doesn't just stop once you've achieved those goals in that moment.
Yeah, great point. And also, like, there's loads of other countries that haven't taught in to know the caliber of physios, by the way, just because I heard your accent. And we're just
yes, you do need to go to South Africa.
Yes, I know.
Yeah.
So just so you know, I haven't been there. So you're not part of that. And I bet they're great as well, because you're here today. Whew, that was a close call. That's such a clever question. What's your name?
Shauna.
Shauna. What was your name? Sorry. Jake. Yeah, I didn't want to, I felt rude. I didn't ask your name, but Shauna. Really good question. And I think one of the things I often don't want patients to develop is rehab guilt, because sometimes they do, and they get to a point of where they're like, if I don't stop doing this, it goes back. And it shouldn't. Like, you want it to get to a point where they can tolerate it and manage it. But the question is really, like, is there going to be, because if you're managing it non-operatively, right? Because you'd hope, like, non-operatively, like, you'd get them to a point, if you're going to get rid of them, for want of a better phrase, they can manage it successfully themselves. Like, you kind of, because otherwise you won't do your plan B or your plan C. You'll be happy with your plan A. But I think there are going to be times where sometimes it might be rear its head again a little bit, but it's about trying to understand the influence of that. Like, if it's a short-term thing, maybe it will come back, be something they can manage. But if it's something that is coming back consistently, repeatedly over multiple, episodes of whatever it might be flaring up, my concern is, like, has it been fully addressed in the first instance? That's the kind of worry that I would have, because whether there are other, pregnancy, I think it's actually like hips, you should be able to tolerate pregnancy and natural birth, even with a dysplastic hip. You know, there's a lot that you can do. The hip and the pelvis is quite robust to adapt with those kind of components. Whether you've got those hormonal changes, like it shouldn't be that should be immediately causing other issues, because, you know, loads of women go through all those things and never have hip pain. You know, especially from a hormonal perspective, I think there's a real lack of insight into how important that is, especially with like tendon-related pathology. But a massive misconception I see with patients and physios is like with our glute tendon patient, like hormonal, perimenopause, menopause. But like loads of women go through menopause and never get anything. Like, so it's not always that's easy scapegoat. So I think there's a lot that can be tolerated even with those. And if it's not, I guess I would want to know why, and then try and support them with that. And when you have got someone who has a longer management program, that's why it's helpful to be involved, because then you can you've got more scope of being aware of these things as well before you just discharge them. But yeah, great question. Do you work with that patient group? Or was that just like...
I do, yeah.
Yeah, that's a smart question.
My insight there is not quite as extensive as that. It's more that it's a new problem. It's a new problem, and it may or may not be related to the old problem, and it just requires a whole new assessment and exploration to reconsider where that person currently is, to respect what's happened before, but it's a new problem, and you start all over again. It might be 20 years before, it might be relevant, it might not, I don't know. And I think that's the main thing that I would be thinking. This is a new problem here, right with me now. What do I need to do to help this person in their current situation?
And I'll go to South Africa. I just need someone to invite me. I can't really just turn up.
I'll get you some connections.
Thank you. That's good. I've got a new gig.
Hi. So I would actually like to circle back to one of the parts that we were discussing earlier about the hierarchy that has been set with the consultants and physios being completely separate to each other. However, sometimes I believe that it's hard to separate those two, especially when the consultants are almost dictating the patient expectations, and then when they come in for their appointment, it's almost like they have been told by the consultant that what you're expecting out of your physio, and most of the times it involves manual therapy, for instance. I would like to know what's your advice to physios who have to deal with patients who are already coming with those preset consultant dictated expectations.
I'll answer it first, just because I know
That's funny.
I threw that grenade in.
I was going to say, do you want to answer it first?
Yeah, I threw that grenade into the conversation, so I'll cover it. So these days, I will explain that the consultant may want you to do this, this, and this, and that's okay. We'll likely do some of that, but in the end, I'm the expert in this side of things. They're the experts in the surgery. I'm the experts in the rehab and the post-op recovery. I may tell the surgeon what I've done. I may not, depending on what relationship I have with that surgeon. But in the end, the patient is the most important person. And if I believe that the best thing for them is to be combining an element of manual therapy, mobility, rehab, and getting them maybe off the crutch a little earlier, as you were using the reference, then I will say that to them. And I'm pretty comfortable with that these days. If I was to have a conversation, in the end, if the consultant's in front of me, I'm going to say the same thing. I'm going to disagree with them politely. And I'll just say, I understand where you're coming from, but I've seen these things and this is how I think things should be done. So while I'm a little bit more bullish about it these days, but I'm pretty willing to, it's the hill I would die on. Yeah. And I'm pretty comfortable to say that.
What he said. It's true though. I think the only thing that I would tell you not to do is be unprofessional to the patient.
Yeah.
So I think that's where I would draw the line. Like, don't, because you would have it not even just with other practitioners. They'll come in and they've seen like Joe Bloggs down the street chiropractor for 3 years and a 10 grand out of pocket. In your head, you're crying, but don't tell them that. Just be like, oh, okay, it's not worked. Well, you're here now, so obviously it's not working. Let's try this. Even though because I just don't think there's any benefit of slagging them off. But yeah, so that's the only thing. But yeah, what he said. Great question though. Good question. It's nice I like these questions when you're 2 hours into listening to us talk and you're still asking questions. It's always a good sign. No one's fallen asleep. Well, I can't quite see back there. But.
Thank you so much, both of you, for a great chat. My question was along the lines of the journey. You've spoken a lot about journeys tonight. You spoke about dysplasia patients and how long the later diagnosis could be, et cetera, et cetera. So my question is about how quickly you feel someone should be directed towards specialist input when they may have already had a long journey. So, for example, let's say a 25-year-old female who is presenting in an NHS clinic, they've had some imaging, it says, oh, dysplasia. Would you be looking for that physiotherapist to try and manage it themselves within their NHS clinic, spend some more time looking at things, or has this patient had so much irritation for so long, delay for so long, emotions for so long, I think that they would be better off being referred to a more specialist input to carry on that journey?
Okay. Good question. There is a fine line by not referring people and referring them too quickly. Even if that person comes to that clinic to see you in an NHS setting and has had symptoms for a significant period of time, the fact that you're even considering referring them shows a fair amount of knowledge and care for that patient. Don't sell yourself short by not giving them that input. Even if it's not going to be the resolution, and someone's had symptoms for 5 years, in the reality, 3 months, not much is going to change. If it doesn't get better, it doesn't get better. But, if you've seen them 3 or 4 times, trust me, you would have added a significant amount of value to that person's individual journey for that stuff. If it gets better, then great. Loads of people have dysplasia. They don't get symptoms. They manage. Great. There's varying levels to this. But I think there's always value to be added. I think if your patient has, and I'm thinking when I would refer first, when they've done the physio, they've done the rehab, they're not getting any better. They've done good quality treatment. They're still not getting any better. And I kind of want to know what the main protagonist is from a pathological perspective and how do you treat that? And if they've already done that, there's sometimes from a consulting appointment, I might do that sooner because that's what they want. They want to know what are my they're not coming for treatment. They come in for what are my options? But from a clinical perspective, what you don't want to do is patient comes into clinic, scan shows dysplasia, they've got dysplasia, refer on, because 1, that could take months. 2, they might end up doing the wrong stuff. They might go on someone's YouTube and then do the wrong kind of rehab. Just give them a toolkit, build a toolkit with an expectation of could do this or could do that. And then we can refer afterwards, because ultimately, what's the referral for? To treat, I guess. Surgeon's not going to just rock up and be like, nice to meet you. They want to do stuff, cut and poke and saw and inject. Fantastic question.
Would you mind if I expand on that? When I say refer on specialist input, even a specialist physio or a specialist young hip clinic or something like that, even if it doesn't include a surgeon?
I mean, the thing is, it would go to them first anyway. So that's the kind of caveat. If you are gonna, I'll tell you when you would want to do it. If you want real clarity on the severity of the pathology and the imaging is going to help guide your treatment in any capacity, then I would suggest that. And that would be those interface services that you can do that. But ultimately, only if it's going to change what you're going to do. And normally they're the gatekeepers to the surgeon anyway. So they're either going to say, we send you for an injection, we send you for surgery, or go and try some physio.
I think what you're asking and almost answering yourself is that we're starting to become a little bit more aware that we can't always fix these things ourselves. It might not necessarily be even lack of knowledge, but the environment you're in might not be best suited to that person's care. And that's okay. There's no slight on you, the person who's got that situation. You just have to be honest with the person in front of you. You may need more significant input than I'm able to offer in this context. And I know a guy, I know a physio down the road, and she's fantastic. And I know this person who's in London, or I know this guy who's called the Hip Physio. Get in touch with the Hip Physio. He does some really cool online stuff. But I think that's what you're getting at, and that's what I really love about what we're trying to create in not just this space here, but across physio as a profession. You don't have to know all the answers. Thanks very much, everyone. That's good. I think that's a wrap.
Well done, mate. Thanks.
Thanks.
Thanks for listening to today's episode. If you've made it this far, that probably means you've enjoyed the show. Please leave us a review and subscribe to the show on whichever platform you use. I've been told that this stuff really does help us to reach more people like you. And if you are someone in charge of things at work, book a demo call with JNAP to see it for yourself. Use code PhysioCoach2MO to get 2 months free. To stay up to date, follow us on Instagram at BetterNeverEnds or on YouTube, the Physio Coach Podcast. This podcast is a product of Better Physio Group, provider of physio and PT services in central London, helping people in pain, suffering with injury to feel better and live better. There's physio, and then there's Better Physio.